Good evening. Welcome you all to this edition of Tamil Nadu ISG meeting. So today we have a packed session in front of us. We'll have 3 presentations by postgraduates, followed by a session on HCC, which will be again, we'll have a small introduction lecture, followed by a panel discussion. So it's going to be a fairly tight program schedule. Dr. Prem, our president, is not able to be here because of some personal commitments. So on his behalf, I extend a warm welcome to all of you to be part of this meeting. So we'll start off with the postgraduate session. To chair this session, I request Professor Nirmala and Dr. Aditya, Madam Dr. Jayanti, please to take the stage and conduct the proceedings, please. Thanks.
Let's start the postgrad session. The first will be by Dr. Muthukrishnan from Department Medical G, SIMS Hospital. Unraveling cause of chronic diarrhea.
Good evening, teachers and friends. Today I am going to discuss a very interesting case of chronic diarrhea, for which I titled as Unraveling the Case of Chronic Diarrhea and Cause of Chronic Diarrhea. We have the history of 13-year-old boy, Master A, studying 9th standard in Coimbatore, came to us with complaints of loose stools since July 2023. History started last year, July 2023, which is loose stools, acute onset, Bristol type 6 and 7, watery. The frequency 5 to 7 times per day, no blood or mucus, associated with 2 episodes of non-bilious vomiting and low-grade fever, for which he doesn't have any abdominal pain, distension. He was treated with a course of IV antibiotics, but his symptoms persist to have which frequency increased up to 10 to 12 episodes per day. He was investigated outside via colonoscopy, which showed a nodular lymphoid hyperplasia of ileum. The histopathology showed chronic inflammation with eosinophilia. Then he was treated as irritable bowel syndrome, diarrhea type. But again, he further persists to have chronic diarrhea. Again, he investigated one more hospital. Upper GI endoscopy showed corpus gastritis, RUT was positive. The colonoscopy showed aphthous ulcers in the terminal ileum. Histopathology showed features of chronic active inflammation. Based on this, the diagnosis of early IBD was made. Then he was started on Budus CR and Pentasa. At this point, the boy referred to us for the second opinion. As of now, when he presented to us, he persists to have a loose stools, 10 to 15 episodes per day, Bristol type 7, totally watery, small quantity, no blood or mucus. There was an nocturnal episodes present, no postural giddiness, no barbarmy, no bloating, no vomiting, no abdominal pain and distension. He had a weight loss of 3 kg in the last 8 months, no fever, no joint pain, skin rash, no perianal pain or discharge, no bleeding per rectum, no swelling of both lower limbs, no oral ulcer, back pain, bleeding comes, no paresthesia or numbness of both feet, no recurrent oral or genital ulcer, no recurrent sinopulmonary infection. The timeline of the history, first the symptoms started July 2023 with fever, loose stools and vomiting. He was treated with a course of IV antibiotics. Then again he evaluated in September 2023. Colonoscopy showed a lymphoid hyperplasia. Then he was treated as irritable bowel syndrome, diarrhea type. And January 2024, he was evaluated in Coimbatore. Colonoscopy showed some aphthous ulcer. Based on the histopathology, he treated as IBD. In April 2024, he referred to us for the second opinion. Past history, he had an appendectomy on 2017. He not a known case of type 1 DM and any thyroid illness. No history of similar illness in the past. His school performance is good. The nutritional history, the calorie deficit around 300 and protein deficit of 3 grams. An examination is not contributory, no external signs of extraintestinal manifestation of IBD, no cutaneous markers for TB, no new cutaneous marker for polyposis syndrome. Vitals are stable, BMI 14.5. The abdomen examination, apart from laparoscopic port scar, normal. Per rectal examination, rectum empty, no mass, nothing. Other systemic examination, normal. The summary, 15 years old old boy with no known comorbidities presented with chronic painless watery diarrhea, which was started after episode of acute gastroenteritis without any features of macro or micronutritional deficiency.
So, what are your differentials? This patient, pediatric, gastro. One quick, you have to be fast. No, come on now. Discuss the case. Your DM gastroenterology, pediatric. What are the possibilities?
It's a 15-year-old.
No more discussion. Just tell what's your differential.
With a history of weight.
Differential. Come to your
Inflammatory bowel disease, TB.
Number 1. Number 2, TB where? Lungs,
He has a history of weight loss.
No, I'm asking you only the differentials. Number 1, you said inflammatory bowel disease, you didn't classify. Is it Crohn's or ulcerative colitis? Just keep the timing, otherwise next case. Okay, then IBD what? Ulcerative colitis, Crohn's? You think
most
Crohn's?
But abdominal pain was not present. But after ulcers was more favor of Crohn's.
Okay, next. So you think it's Crohn's. Number 2?
Luminal TB.
Luminal tuberculosis. What? Small intestine? I say this patient is actually having loose stool. He's adding water to the stool. What is the quantity of?
Around 100 to 200.
Have you seen?
I have a video.
Show that video.
Yes.
Show that video first. Children, that's the first thing you'll have to say. There's no clinical manifestation. There's no nutritional deficiency. Everything. What are the things that you would consider? Is he going to school?
Yes, ma'am.
So how often he's disturbed in school? He cannot attend classes, no, if he's passing 12 times a day.
He actually is in recurrent leave.
So no, in between is he normal?
Ma'am?
Is he normal in between?
No, ma'am.
So then he has to be on leave. You cannot have 12 stools and attending a class.
But
These are the
when
things that
he
should cross
going to
your mind.
home, school is wearing diaper very often.
But it gets soiled. It has to get
Yes,
soiled.
yes.
Any dehydration requiring admission?
No, ma'am. Only 3 times he was admitted.
Night time? What's the nocturnal? You have not mentioned anything of the nocturnal frequency.
He had occasional nocturnal episodes, ma'am.
No. In 6 months, how many times he passed at night? Just keep a watch on the timer. Otherwise, I'll just be exceeding. I have to leave. How many times at night? 6 months.
I didn't ask the question.
That's most important, no? Person who's passing 12 times during the day and not passing at night. Are we dealing with a functional diarrhea? Child who has, he's doing whatever he wants and he's adding water to the stool and doesn't tell anyone. And actually, because with this much of an illness, the BMI also reasonably okay, child not attending classes. So can we have the video of that?
Yes, ma'am.
Just show the
I tried
video.
to play, ma'am. It's not
Yeah,
playing.
try to play the video. So your DD.
Immunodeficiency, HIV.
He's well. He's well.
He has
Look at,
lost
there's no
weight.
nutritional. He's deficient in protein only by 3 grams. His calorie intake is also okay. So what are we dealing with? First is you have to say whether it's organic or it's functional. That's the first thing, no? In a child.
But he has lost weight.
3 kilos weight. You don't take it. So what's a gastrocolic reflex? Those are things you have to ask. There's no rumbling, there's no borborygmi, there's no nutritional, no hypoproteinemia, no cheilitis, glossitis, nothing is there. In a child who's passing 12 times use motion per day.
Post-infectious inflammatory bowel syndrome.
Post-infectious
Just irritable bowel syndrome, IBS.
In a child, you'll make a diagnosis IBS 12 times motion in a day. What test do you want? What investigations you want? Examination negative. What investigations you want to come to a diagnosis? Quick.
Stool examination.
What do you want in stool?
Stool, ova cyst and occult blood.
Which ova and cyst will cause watery diarrhea?
Cryptosporidium.
So what will you ask in stool?
Stool.
You'll ask stool routine, no?
No, we have to specifically ask for cryptosporidium.
So
And if it is
what's the special stain for cryptosporidia? Oh, you've not. She's not come for my class.
This is the video.
That's the water. So what do you think it is? Now he's passing water in the stool. Enema kurtutu water kurtabarik. Whether he's inducing an enema and then passing water. It's actual water, right?
Yes, ma'am.
But this is how many minutes, how many seconds? No.
For 38 seconds.
For 38 seconds he's passing watery diarrhea.
Yes, ma'am.
How much will be the volume?
Is Around 100 ml, ma'am.
100 ml. It'll be dehydrated, no? Okay, continue.
Yes, ma'am. இது என்னண்ணே வர மாட்டேங்குது. இல்லை, இது வீடியோ ஆன் ஆகிட்டே இருக்கு. க்ளோஸ் பண்ணிடுவா. It's the investigation. Is hemoglobin 12.5, WBC count 7,960, platelet count 3 lakhs, sodium potassium within normal limit, TSH 1.8, random sugar 97, transferrin saturation 10%, CRP 0.5, serum chromogranin 45 nanogram per ml. It's the video I already showed. Can anyone guess the diagnostic test that was done?
Yes, I will keep a person next to the patient and not allow the child to go anywhere and watch what's happening throughout the day. That's the only treatment I'll ask. That's what I would do.
Yes.
Just tell the mother, or not even the mother, not to leave even for 1 minute.
Yes.
Just be by the side and get it done. That's the first level 1 investigation. What happened?
Actually, we collect this sample and send for the stool biochemistry, ma'am. Stool sodium, potassium and osmolarity. The stool sodium is 11, potassium less than 2, and stool osmolarity 74. Actually, we thought of using health faucet to irrigate the rectum and continuously passing. The stool osmolarity less than 250 is equal to the factitious diarrhea. Yes, our patient had a 74 of stool osmolarity. The diagnosis was made factitious diarrhea, and treatment
Yeah, 5 liters water, no? And I mean, this we know. So incidentally, I would not do chromogranin and all. For me, I'll just sit with the patient and say, now you pass. That's it, no? That's the treatment. You won't do chromogranin, osmolality and all. This diagnosis is, I thought maybe I may be wrong, but it turned out to be right. So we had a child who had constipation, and he will say, I was passing motion once in, this is in Peripheral Hospital, Anna Nagar, once in 10 days. So Malti and I, we were just wondering what was happening and all, you know. And so we gave a SIDS marker study, and lo and behold, next day it was empty. No, all the markers had gone. So he's feigning. He's telling that I've got constipation, I don't pass. The grandmother thinks the child is having all sorts of things. Likewise, he went to all the pediatricians and all, again 12, 13-year-old boy, and he was being treated. So we just did this SIDS marker study, and we found all the 20 markers were out. Thank you.
Thank you. Yes, few points regarding.
So what was he doing? So tell us, what was he doing?
Actually, I called him on 10 days back, ma'am. But still, he had a. But patient not accepting his factitious
So
diarrhea
basically,
using.
you'll have to demonstrate the 24 hours, you know. Just have to be with him for 24 hours and just be with him and see what happens. Does he pass motion at all or not? That's it. Thank you. It's a spotter. You know?
Yes, ma'am.
Why was he? What was the reason for his?
We not able to. Yes, psychiatric counseling we given, ma'am. But basically, he refer from Coimbatore, ma'am. From LVK sir, from refer to Ramkar sir.
No, I'll talk to him. Okay. I would not have admitted. I would have just told you stay with me for 24 hours. That's it. Thank you.
Thank you.
Thank you. Give a why. Clap, clap. You have some more slides?
Yes, ma'am.
Quickly,
Some
just-
few cause for
No,
diarrhea.
No.
Or
This is
some-
out of context. You tell us factitious diarrhea.
Yes, ma'am. Factitious diarrhea is self-induced true increase in stool volume or adding some various substances can cause abdominal pain, weakness, dizziness, orthostatic hypotension, may extend to cause malnutrition, weight loss. The stool biochemistry, we can prove that is factitious diarrhea or not. If stool osmolality very low or very high, we can say factitious diarrhea. If stool osmolality less than 250 is patient adding water into the stool. If it is more than 400, patient adding urine into the stool. If osmotic gap is more than 70, is osmotic drugs as the addictive substance, drug abuse substance. If less than 70 is a secretory drug abuse. Colonoscopy, sometimes they have a melanosis.
That's not secretary, it's secretary.
Okay. Okay, ma'am.
Spelling.
Sometimes patient have a melanosis coli and chronic colitis-like features. Treatment mainly correct the
So what's the
dehydration.
learning point, no? There's no pain, so IBD will never come as a DD. Never label an IBS unless proven otherwise. I think that's an important message. And adults, at least, we have watery diarrhea due to drugs. That's why I asked. That's one thing. You'll have, in the olmesartan, they'll just pass water. But they'll not get dehydrated. Actual water, secretory diarrhea. You stop the olmesartan, it just stops. That is autonomic entropathy, autoimmune entropathy. That is autoimmune entropathy. And autoimmune entropathy can get watery diarrhea. So that is an important DD. Microscopic colitis in adults can present as watery diarrhea. These are only few conditions, but they'll have crampy pain, they'll have that, so you'll get that information. Thank you, doctor.
Thank you, ma'am.
So important, good history taking. See, that's all that you need. Only thing you need is a good history. The history will give you a clue. History and examination will give you a clue to the diagnosis. Thank you.
Thank you, ma'am.
Next case will be by Dr. Megha Sharma, Medical G, Apollo Hospital. Twisty tails, a missing tail and a gut bandhan.
A very good evening, everyone. I'm Dr. Megha from Apollo. So as we have already known about the title, it is Twisty Tails, Missing Tail and a Gut Bandhan. So we are talking about a 21-year-old male college student from West Bengal, came with chief complaints of loose stools for past 2 years, abdominal distension from past 2 years, associated with abdominal pain for 6 months, with worsening of the symptoms from past 1 month. History of presenting illness. The loose stools were watery in consistency, around 6 to 7 episodes per day, moderate to large in volume, yellow colored, not associated with any blood, mucus, urgency or tenesmus, but were associated with nocturnal episodes. Initially was intermittent, lasting for 2 to 3 days. Now it has become continuous for past 1 month. It is not aggravated with any specific type of food, not reduced with fasting, and there is no history of difficulty in flushing the stools. The abdominal distension was diffuse, gradually progressive, associated with ball rolling movement all over the abdomen. Abdominal pain was also there, which was diffuse, crampy, intermittent, and used to reduce with passing stools. The reduced food intake, he also gives history of reduced food intake, which he attributes to the pain abdomen, but the appetite was preserved. He has lost around 10 kgs of weight over past 1 year. Past history, for the loose stools, patient used to take medication and IV fluids from local doctor, following which he used to get some relief. He was evaluated with routine blood tests, which were normal. There was no history of abdominal surgeries, no addictions, no high-risk behavior, no diabetes and tuberculosis in past.
The distension would come down with passage of stool?
Yes, ma'am. That used to reduce with passage of stools.
So he would
Pain
get
and
distension,
distension.
he'll get a pain, he'll lose stool and it disappears.
It
Distension
reduces,
comes-
ma'am. It will not disappear, ma'am, but some relief in pain and distension he used to feel. Some relief.
No vomiting.
No vomiting till now. On examination, journal physical examination, patient was well oriented to time, place and person, lean built, BMI of 19.4 kg per meter square. There was no pallor, icterus, cyanosis, clubbing or any lymphadenopathy. On abdominal examination, inspection, abdomen was distended with visible peristalsis. The bowel loops were palpable. There were no tenderness. There were tympanic note and percussion, and bowel sounds were present. You can quickly
PGs,
see that.
who are the postgraduates here? I don't know the senior, the DM postgraduates. Quick, what are the...
So
what
they
is
were
dealing-
mildly increased, around 5 to 6 per minute, sir.
What are we dealing with? PGs? No, I don't know the PGs. Arun. DM postgraduates, what are your differentials in this patient? Come on. What are your differentials in this patient? Abdominal pain, visible peristalsis, give us, and loose stool. What are we dealing with? Pseudo obstruction? True obstruction? SIBO? What are we dealing with? What are the possibilities? No one wants to take the turn.
Try, doctor, try.
Any history of lead?
Yes, sir.
Lead.
I didn't ask ma'am specifically.
You didn't ask for the lead.
Yes, ma'am. Sorry.
What are the possibilities? Can it be pseudo obstruction? Would you get pain in pseudo obstruction? Pseudo obstruction, you can get discomfort, no? You may just find visible loops. Most important is with the diarrhea, the entire thing should become normal. So SIBO is one possibility. Along with that, dilated bowel loops, patient is otherwise okay. Then pseudo obstruction, no? One of the myopathic or neuropathic. One of those conditions is what you have to consider as one. Only thing, pain is not a feature. But pain can be a feature if there is a narrowing due to that. Supposing it's only small intestine and not the colon, then it makes a difference. Any other differentials you'd like to consider? What was your take, differentials?
Yes, ma'am. We basically thought of some pseudo obstruction, we thought of pseudo obstruction only, ma'am.
Oh,
mainly.
come on, yeah. Just because I said pseudo obstruction, just a myopathic, neuropathic combination. What is it you're thinking? What is it?
He didn't had any other features, so we kept it like neuropathic.
Neuropathic.
Ma'am, it was going on from past 1 month, recurring every 1 year, and it was recurrent. So subacute intestinal obstruction can be kept in.
So
kept as
the
it is.
thing is, I've seen a young girl, no, who's 14-year-old, who had this. She'll always have one abdominal distension. When you see her, you'll find all these bowel loops, and she'll have diarrhea. So one of the surgeons saw that and operated, and she died. Because surgery is not an indication. It's not an indication. Either you do an ileostomy, allow the decompression to take place, and place a ileostomy back. But if a person, so most important is that message. Pseudo obstruction is an important. Can we have the plain X-ray abdomen of this
Yes,
patient?
ma'am.
That's the diagnosis. What you can see everything, no? There are Sibyllis mass in the rectum and the whole loop.
Large bowel, ma'am.
Cecal volvulus, sir. It's not a volvulus.
It's a volvulus.
It's a
ma'am.
volvulus.
Sigmoid
It's a-
volvulus.
It's a
ma'am.
volvulus.
Yes, ma'am. Sigmoid volvulus.
Sigmoid volvulus.
Yes, ma'am. We also
So
did
what was the rectal examination? Sigmoid volvulus.
PR was empty, ma'am. Empty, ma'am.
Empty.
Yes, ma'am. It was empty.
So what test would you do to manage this patient? One investigation that will tell you that it is pseudo obstruction. Sigmoidoscopy, decompression, no? That's all that you need. Decompress, the whole thing will turn around. Come on, continue.
Yes, ma'am. We also did routine blood tests, which were all normal. It was not significant. We went ahead with, after X-ray abdomen, just to confirm our findings, we went with for a CT.
No, not a CT for a pseudo obstruction. Come on. Poor patient, 12,000, 18,000, 21,000 gone. Okay, continue. I mean, with an X-ray abdomen, the message should not, please, all the students and all here, please don't carry a message that you need a CT. What you need is just a colonoscopy or sigmoidoscopy, decompress, and the whole thing will settle down. That's it. So what treatment would you offer for this patient?
Ma'am, after decompression, we should go for surgery because it is recurring. It can recur again and again.
Sigmoidopexy.
Sigmoidopexy.
So you want to give any information, any discussion, or?
Yes, ma'am. We have. So on the CT, we could see the twisted sigmoid mesentery along with sigmoid volvulus. There were also dilated loops of the descending colon, ascending colon, and the transverse colon. Along with that, we had an additional finding of absent distal body and tail of the pancreas. So the final CT report was twisting of the sigmoid mesentery suggestive of sigmoid volvulus with significant dilatation of sigmoid colon of approximately 11 centimeters in diameter. The descending colon, transverse and ascending colon were also dilated to a maximum diameter of 6.5 centimeters. There were no features of bowel ischemia, no free fluid, small bowel were normal, and along with that there was dorsal agenesis of pancreas. So we kept a diagnosis of chronic sigmoid volvulus with dorsal pancreas agenesis. Patient was admitted, he was kept NBM, IV fluids were started for optimization. The flatus tube was inserted for bowel decompression. Within 2 days, his bowel was decompressed. And after that, after final optimization, we took the patient for surgery for laparoscopic sigmoid colectomy.
What was the small intestine like? Normal?
It was normal, ma'am.
Small intestine was normal?
It's normal, ma'am. It was not distant. These are the intra-op pictures of significantly dilated sigmoid colon. So we did a sigmoid colectomy with side-to-side colocolic anastomosis between the descending colon and distal sigmoid colon in 2 layers. On gross appearance, the dilated intestinal loop of 42 centimeters in length was seen. The external surface looked congested. There was loss of mucosal folds and flattening of mucosa. There was no infiltrative lesion or any definitive growth. Attached mesentery was flattened and sectioning through the mesenteric showed the blood clots within the blood vessels. On histopathology, the resected sigmoid segment had patchy subserosal congestion and mucosal ulceration along with mesenteric vessel thrombi, which was suggestive of intestinal ischemia. No ganglion cell loss, and there was no nerve thickening noted. On follow-up, post-op follow-up, patient is now doing well. The stool frequency has come down to 1 to 2 episodes per day, which are formed now. So,
you can just make it brief, just tell the salient points.
Yes, ma'am.
Tell us the tips for diagnosis and management.
Actually, ma'am, we thought of, because we had chronic sigmoid volvulus along with the pancreatic agenesis. So we had some literature search. We found that both of these structures actually develop at these almost same time, around 5th week of gestation. So we thought that it might be a common association, might be some embryogenic arrest during the 5th to 6th week of gestation, which led to both of the abnormalities together. We also found that we have some case reports on sigmoid volvulus as well. If I have time, I can discuss. They are usually young males they can present with chronic constipation or chronic diarrhea as well. Most of them are managed with surgical sigmoid colectomy. There's another case report from Mayo Clinic. This patient presented with chronic constipation, which was evaluated and thought to be possibility of Hirschsprung's disease.
Did the patient have long mesentery?
Yes, mesentery. Sigmoid mesentery was long.
It was long.
Yes. So, dorsal pancreatic agenesis, as I've told, that it's also a very rare entity. Around only 100 case reports have been reported since 1913 to 2021. Prevalence of around 1 in 10 lakh. It is associated with the HNF1B gene mutation. So basically, what we thought, why are we discussing this case today is the chronic sigmoid volvulus is a very rare entity, and association of dorsal agenesis is another rare entity. The combination of conditions in an individual can be explained by possibility to arrest of embryogenesis around 5th week of gestation, and a rare possibility of heterotexia syndrome should be kept in mind. So I would like to discuss something about heterotexia syndrome. It is a Greek word which means heteros means other than and texis means arrangement. Heterotexia syndrome is due to primary defect in lateralization of the thoracic and abdominal viscera, leading to maldevelopment of asymmetric organs, sparing the symmetrical structures. As we all know, the situs inversus is a mirror image orientation, usually does not cause any health problems. But in heterotexia syndrome, arrangement of the internal organs somewhere between the situs soleus and inversus, so it is also called as situs ambiguus. The causes of it can cause serious health issues. The prevalence is around 1 in 10,000. It is more common among Asians. 90% of the cases are usually sporadic. Signs, symptoms, and severity usually depends on the number of organs involved. And the syndrome complex can have polysplenia, asplenia, cardiac anomalies, abdominal heterotexia, short pancreas, malrotation of gut, or major vascular abnormality along with bronchial malformations. And this we have already discussed. So more than 20 mutations have been discussed, but 3 mutations are known to be quite common to be associated, which are DNA H5, DNA I1, and GJA1. So it can also occur with other genetic syndromes like primary ciliary dyskinesia. In some literature, I found that there are certain maternal factors which can be associated, like maternal diabetes, maternal smoking, exposure to hair dyes, cocaine use, and chemical exposure like pesticides and organic solvents. So I could not find any similar case report like that of our case, but there is one case report from India, Telangana, for heterotexia syndrome, in which there is agenesis of dorsal pancreas along with the polysplenia.
So what are the learning points in this patient? What went wrong, you think, in Northeast?
Because the abdominal distension.
Plain X-ray abdomen, just a plain
Yes, ma'am.
X-ray abdomen. Had they just taken a plain X-ray abdomen, they would have come to a diagnosis. Nothing more than that, that's all.
Yes, ma'am.
That plain X-ray abdomen gives a clue. History itself gave a clue. I was just telling it's a case of pseudo-obstruction.
Yes, ma'am.
Because the distension does not come down.
Yes, ma'am.
The distension continues to remain even after the diarrhea, which means there's a permanent
Obstruction,
neuropathic or
discussing.
myopathic component.
Yes, ma'am.
And the diarrhea is due to SIBO.
SIBO, yes, ma'am.
SIBO.
Possibly. Or might be because there was some mesenteric ischemia on the cross-section
No,
also,
no,
we
no,
thought
not
might be
ischemia.
chronic ischemia.
Not in this patient. Where will you get ischemia here? It is a sigmoid colon, no?
Yes,
So no
ma'am.
question of ischemia. Thank you.
Thank you.
Next case by Dr. Jagdish, child with growth retardation and chronic diarrhea from Rail Hospitals.
Hi. Good evening, dear all. So probably I'll be discussing about a child who came to us with multiple symptom complex, of which the upfront manifestations were growth retardation and diarrhea, but this child had multiple issues when the child came to us. So this is a 13-year-old girl child, basically native of Nagapattinam, who was born to non-consanguineous parents, who started having symptoms actually from 14 months of age. And when the child came to us, the child was like 13 years of age. So basically, I would like to describe the symptoms with respect to the semiology, because I don't want to interrupt the natural history of whatever it is. So I won't be I won't be discussing about the examination and all in between. I would like to maintain the originality of symptoms. So basically, the first symptom that the mom noticed was the child was having letharginess, and the child was noted to have anemia with respect, and the child was getting pale actually. And this child was also having failure to thrive with poor height and weight gain. Later, the parents noted that the child started getting chronic diarrhea. Somewhat it was intermittent, and sometimes they could see that the child also used to get sometimes constipation too. Intermittent black tarry stools were also noted. That was noted from 4 years of age. And the child also started getting spasmodic pain abdomen associated with abnormal sounds from the abdomen, which was like a borygmy, and progressive abdominal distension. All these symptoms were actually episodic in this child. So let's talk about the pallor the child had. So as the age advanced, the child's pallor started worsening. There was episodes where hemoglobin would drop up to 2 grams. And the child used to receive regular transfusions, and she also received IV intravenous iron therapy. Sometimes she was symptomatic with occasional dyspnea and associated with obviously a significant standing. The loose stools frequency was around 8 to 10 times a day. There was actually history of nocturnal stools. Sometimes it used to be intermittent, alternating with constipation, but majority of the times it was actually loose stools. And there was a transient response to antibiotics. Initially, the mom felt that the black stool was due to the oral iron therapy, but later they noted that the stools were getting tarry in consistency, and it was looking like a melena kind of stool. Never they could see any fresh GI bleed, and there was no history of any frank NG bleeding. Abdominal distension, already there was some periodic exacerbation. There was abnormal sounds from the abdomen. This pain abdomen actually was intermittent, and it was somewhat related to the intake of food. And when the child had a NPO status of the child was not taking any food, the child didn't have any pain abdomen. So with respect to these symptom complexes, I think if we analyze, this child has scattered symptoms which may not be related to a single system involvement. The possible differential diagnoses included were inflammatory bowel disease, upfront Crohn's disease, immune deficiencies like HIV or genetic cause of immune deficiency, blind loop syndromes, vasculitis, which actually can have multisystemic manifestations, eosinophilic disorder, NSAID enteropathy, but there was no history of any NSAID intake. Then at last, abdominal Cox lymphoma and celiac, because these disorders, if untreated, will not last until 14 years of age actually, if the onset is at 1.5 years. So when we look at the symptom complex, these symptoms were not fitting into a single disease entity completely. So that was the first red sign in this child. So this child was initially seen by a hematologist because the main concern of the mother was the child used to get admitted each and every month for blood transfusion or for any intravenous iron therapy. So they did the workup for anemia, in which they have ruled out hemoglobin-related disorders like thalassemia, G6PD deficiency, spherocytosis, etc. They even did a bone marrow, which was actually showing a normal RBC lineage in the marrow. There was a severe iron deficiency with extremely low ferritin stores in this child. And later, they thought of some gastroenterological cause. Then they referred to a gastroenterologist where they have done an upper and a lower G endoscopy, which was not showing any active lesions. They saw up to terminal ileum. There was no ulcers or anything in the endoscopy. As a part of the failure to thrive and anemia and all those things, TTGA was also done, even though the child was from South India and the TTGA was negative. And they have documented an ultrasound which was normal, and a CT scan or an X-ray was not available at that time. So later, this child, in between a span of 4 to 5 years, were going around, and finally they landed up with one more hematologist where they wanted to look into RBC's dyscrasia, for example, the congenital dyserythropoietic anemia syndromes, and they directly went to do a whole exome sequencing, which specifically actually noted this SLCOA 2A1 mutation, which is a disorder like a PHOA, which dominantly involves the bones and joints actually. So this apparently on appearance has nothing to do with a gastrointestinal cause, in fact. So finally when the child came to us, the child was actually 13-year-old, vitals were stable, the child was severely stunted and wasted actually. The child was looking pale. In fact, there was a grade 1 clubbing. Abdomen was looking mildly distended. It was actually gaseous. It was having a tympanic resonance. There was no organomegaly or ascites. There is no gross skeletal anomalies. The hemoglobin was extremely low, and the rest of the inflammatory parameters and LFT was looking normal. So basically, we have a genetic mutation which is actually written as a homozygous, and it is an autosomal recessive mutation, and we have this symptom complex without any skeletal changes. So what is this entity? Does this genetic correlate with the condition of this child? So there is a condition called cryptogenic multifocal ulcerative stenosing enteritis, which is a specific entity related to this genetic mutation. And when we inform the radiologists that we are suspecting this condition, they actually reported the same, in fact. So you could see that there was multiple strictures inside the ileum with intervening areas of dilatation with a perfectly normal colon and upper GIT. I mean the stomach, in fact. And later when we did the technetium scan, we wanted to know from where the child is bleeding. They couldn't identify a focus in the small bowel, but they could see that the bleed was noted after 1 day, in fact. And it was a chronic bleed, and this bleed was accumulating in the large bowel, probably in the transverse and the descending colon, and the tracer uptake was actually noted in that area. So basically the bone scan we did, which was normal, we wanted to look for the bone changes associated with this. The echo was noted as normal. The rest of the workup actually was normal. Basically we wanted to look into one more entity called as myelofibrosis, which also is a part of your SLCAO 2A1 gene, in fact. So basically, when we discuss about this mutation, it is a prostaglandin transporter. In fact, this gene, what it does, it actually stops the prostaglandin from getting degraded. So that means that when this gene is actually mutated, your prostaglandin levels actually goes up. So when the prostaglandin, the local synthesis of prostaglandin actually goes up, it damages the tissue, especially the intestines, especially the focus is on the small intestine actually. And sometimes it can involve damage to the skeleton too. So in the bones, we can get some cortical thickening kind of thing. They can have acro-osteolysis. Skin can also get thickened. There can be myelofibrosis in the marrow, and the GA manifestation that we saw in this patient is CMUSC. It is a rare illness which is characterized by chronic and relapsing ileus kind of status. Until now, 150 cases are actually reported. In India, only one adult patient has been reported. It's probably the first child from India who is reported to have, I think most likely, this is the first child from India who is known to have this disease with an onset at 1.5 years of age. They present with multiple small intestinal fibrous strictures, multiple shallow ulcers of the bowel. They can have intestinal obstruction, and most likely the cause of diarrhea is a small intestinal bacterial overgrowth associated with some enteropathy, because they can have actually superficial ulcers in the small intestine. And initially, people thought that this is basically a vasculitis, and somebody, if they do a small bowel enteroscopy and did a biopsy, there won't be any vasculitis actually, it will be a non-specific ulcer formation in fact there. So what happens in this disease, because of the uncontrolled prostaglandin synthesis, it stimulates a lot of transformation growth factor beta there, which increases the synthesis of fibroblast. In fact, they release a lot of molecule which causes intense fibrosis in the intestine. There can be a local inflammation without any vasculitis, because these cells, these cytokines still actually they attract the plasma cells into the tissue. So when compared with Crohn's disease, the fibrosis intensity is extremely high in this condition, which is one of the differential in a histopathology examination. So we already saw the clinical features. They usually have multiple relapsing ileus. They can have chronic GI loss, diarrhea with malabsorption, altered bowel habits, growth retardation. And one more interesting features which has been reported is requirement of multiple laparotomy, because they may sometimes land up with the surgeon with a subacute intestinal obstruction for which the laparotomies, and there are patients who have required multiple laparotomies to cure this issue, rather control this issue, not to cure this issue. So there is a diagnostic criteria which has been there. So the single most important clinical sign that they say is a persistent and occult blood loss from the GIT, and the confirmatory finding is either by histology, radiology, or endoscopically. So if you have one of the criteria, like among this investigation, it is actually diagnostic of CMUSC. So how it is different from Crohn's disease? Crohn's disease, we know that they don't have frank melena kind of thing, unless it is an extremely rare phenomenon actually in Crohn's disease. And anemia is extremely striking in this condition. And stricture formation in Crohn's disease is extremely less in a child who is less than 5 years of age. They have very shallow ulcers, never deep ulcers. The ulcers will not change into a cobblestoning appearance. Cobblestoning basically because they have intervening areas of fibrosis and the cells are trying to regenerate. That is why the cobblestoning usually happens. And in this condition, because they are superficial ulcers, there are no cobblestoning formation, fissure or fistula formation in long run. Colonic involvement is not known. There are no signs of systemic inflammation. When you have advanced Crohn's disease, we know that the patients can have very high CRP, ESR, inflammatory markers can rise, but in this patient, the inflammatory markers were actually normal, and it is actually like fitting into the this thing of CMUSC. Skeletal features may be seen, and the most important feature is advanced disease in CMSC responds brilliantly to corticosteroids. Crohn's disease, we know that in an advanced stage, they usually require biologicals. The response is not good, but usually they respond extremely brilliantly to corticosteroids. I think there are reports in which they have mapped the involvement of intestine in patients affected with CMUSC. I think the most common site of involvement is the ileum, but we can see that none of these kids had involvement of the terminal ileum. So absence of involvement of terminal ileum in a suspected patients with Crohn's disease actually points towards CMUSC as one of the important differential diagnoses, in fact. So I have actually compiled the cases reported until now. This is until December 2023 actually. We can see that this disease predominantly presents to an adult gastroenterologist rather than a pediatric gastroenterologist actually. So we can hardly see that 2 to 3 kids are there who basically had this diagnosis until now. So it can have a varied kind of clinical presentation. Treatment is basically with steroids. This disease responds actually brilliantly to steroids. Second line is basically with azathioprine. Biologicals may have a role. If there are strictures which are not responding to steroids, balloon dilatation with endoscopy can be done. Surgery is usually offered for refractory cases to avoid short bowel syndrome, and we really don't know what is the role of intestinal transplant and a stem cell transplant in curing this condition, in fact. But one aspect of this disease that we know is that, for example, in our child, this patient had brilliantly responded to steroid, and also the child has responded to azoran. totally asymptomatic, there is no diarrhea, there is no intestinal obstruction, but the bleed was still persisting. Then we started the child on tranexamic acid. The stool color is normal now. This is the first time actually she is saying, the mother is saying that stool color has become perfectly normal in this thing. So we really don't know why the tranexamic acid does a role there. So that is why GI bleeding may respond to tranexamic acid, and sometimes they say that it may respond to estrogen analogs also. This child had gained 2 centimeter height over 5 months, and our basic thing is to repeat a CT abdomen in follow-up to know how the intestinal obstruction has resolved. The child looks clinically better, and if the child is not gaining height, to start with the growth hormone replacement therapy. So basically, it is a rare genetic disorder, differential diagnosis of a patient who comes with chronic diarrhea, subacute intestinal obstruction, who needs recurrent laparotomy and GI bleeding. Anemia of unknown cause, I think we have to evaluate for a focus in the GIT. Genetic report, we have to meticulously evaluate with clinical features. Sometimes we have this reporting as variants of uncertain significance written in the report. It may be uncertain for the geneticist, but for the clinician, it may be quite significant, in fact. And the long-term outcomes are extremely variable, and steroid response is actually a good sign in this disorder. Thank you.
1 year back from MMC, they presented one CMUs in the same auditorium, same place. And
Okay,
last month when we had this Crohn's IBD conference, no, there's a Bangalore Dr. Nagendra had presented a similar case. CMUs is being reputedly, now it's being reported frequently. Maybe Nagendra had a genetic test done, but MMC didn't have a genetic test. Even we have 2 cases, but we have not done a genetic test. But only thing that they presented similar. Only we have presented differently in your case, and in these cases, what case we have seen, bleeding has not been a very prominent. The more like protein losing enteropathy, failure to gain weight, and similarly that was the presentation. But only thing yours, bleeding has been the best. That's why it went to the hematologist and came back.
Yes, ma'am.
Maybe that's why it was. And why didn't you plan an enteroscopy here?
Yeah, yes, ma'am. Actually, since the child had multiple investigations, the parents were not ready at that time when we counseled them that the child needs an enteroscopy, because recently had. In fact, yes.
I think once there is melena and a drop in hemoglobin, I think it's purview of the gastroenterologist and not the hematologist.
Yes, ma'am, true.
No, there's a blood loss.
Correct.
There is a blood loss. There's a frank blood loss, so then it is a losing state.
Blood
losing state. So hematologist really will not have it. It will come as iron deficiency anemia.
Yes, ma'am.
What were the other things you said? One is you said GI bleed. What are the other?
Ma'am, the child had a pain abdomen with features of
you said other system, multiple.
Yeah, they can have actually skeletal anomalies, ma'am.
Anything else?
They can have actually skeletal anomalies. In the index child, it was only gastrointestinal presentation. There was no skin.
You mentioned at the beginning that we are not discussing the others and only highlighting this. So I thought whether there were any other symptoms associated.
No, ma'am. No.
Nothing else.
No.
Lucky that you responded to steroids. It generally doesn't respond to any of the treatment.
Yeah.
What we have seen doesn't respond, but lucky that your patient responded to steroids.
Yes, ma'am.
Any other?
Thank you. Thank you very much.
Okay, thank you, ma'am. Thank you.
Go on to the last presentation.
Madam, mic.
A review of Indian literature, episode 9, EHPV in children. Speaker, Dr. Deepa. Guide is Dr. Nirmala, Head Department of Pediatric Gastroenterology, Institute of Child Health.
Good evening, everyone. I thank everyone for giving me this opportunity to present a review of Indian literature on EHPO in children under the guidance of
As I have to leave a bit early, so just just excuse me for that. So we are planning to start with permission of the Secretary and the President. We just thought we'll have 2 studies as part of the Tamil Nadu chapter, 2 simple studies. One, we thought we'd just take profiling of hepatocellular carcinoma in the Tamil Nadu state, and the other one is alcohol drinking pattern. Very simple, 4-5 questions, and I think we can plan for a completion in 3 to 4 months' time. And just get some data from all the government hospitals as well as the corporate sector. And it's very easy, simple, no? Just age, gender, an etiology factor, stage of the disease, and if anything was done, an etiology. Just 5 questions For the alcohol bit, we'll take controls as those coming to the master health check who are drinking, but ultrasound is normal. So to take up the HCC, I've requested Sumati to take up the study. She'll be the lead person. We want someone who can take up the alcohol. Hema, you'll take up? I think one of you has to take up the lead. So we'll be there to help you out. We'll plan out and we'll start by 1st of August. I think that time is sufficient. It is nothing much. We're not going to disclose any patient's detail. It'll be straight going into the basic, just the drinking pattern and what is the spectrum in alcohol-related liver disease as we see in the outpatient clinic or as inpatient. And if we can get into the community, I think that will be best. So some of you have the community, you have the clinics and all. So there we can get into the community and then see what's the drinking pattern. Any thoughts, anything? Dr. Murugan, Dr. Dinesh, anyone would like to comment on this? These two simple studies. I thought we don't have data. We don't have any data. And this way, the corporate sector will get a lot of cases from Northeast. So we'll get the profiling of Northeast, including HCC. Sorry? No, that is a person who comes to the clinic, we just ask, do you take alcohol? That's a common question that we ask, no? And if he or he's taking alcohol, we just ask what's the quantity, what
Not
it is.
targeting patient with a drinking problem.
Not necessarily.
Okay.
It's just a profiling, sure. Just to see whether the quantum of alcohol, the brand or something has some factor or it's nothing to do. No diet history, nothing. We'll just get the spectrum and just see what's happening.
Start and see how it goes.
We'll just see how it goes, yeah. Sorry? Objective is, see, we don't have, I think except Oli had written one paper long time back on hepatocellular carcinoma, but we don't
in alcohol. What will be the objective
alcohol,
of this?
see, I mean, when a patient comes and says, no, he drinks alcohol for 30 years, nothing has happened to me, it has happened to me. I do not know why. We're not doing genetic studies or anything, but this way we may get, maybe it's a brand, maybe it's a quantity, not just simple questions, just the age, what's the state of origin, and what's the spectrum. We'll also get the duration of alcohol and the spectrum of liver disease. That also we don't have. We don't even have that data. Say 20 years of alcohol with this much causes hepatocellular carcinoma or this much causes cirrhosis. Do we have the data? Any published data? If any of you can tell, then we can use that as a baseline. We don't have any publications on the simple topic on alcohol-related liver disease from our state. Anyone has any publication, you can come forward. No, European data is, I mean, we don't, see, Andhra is different from Tamil Nadu state. So I'm just saying, let us see what's happening in Tamil Nadu state.
No, you said you wanted some reference, so we can look it up and see how
references. I started doing this in Ramachandra Hospital, but I could not complete it. So the data was coming up, but we could not. So the controls will be the master health check patients who are taking alcohol, but ultrasound is normal.
So we should use physicians' help also, I think.
Yeah.
Because they'll see more than we do.
Not necessarily. What I'm saying is it's too difficult to move beyond our realm, no? So let's just hang on. Let us just take the lead. You don't need physicians' help. I mean, the number of cases Stanley sees, I think in 1 month's time, they'll give us all the data. I thought we'll just keep the time as 3 months and not consider the number of cases. Because that way we'll get a wide spectrum. I think you'll get about 2,000, 3,000 cases in no time in 3 months.
Sure, ma'am.
Okay? So Dr. Pirmanayagam and Dr. Prem, you can collect the core group, have a mix of both. Women have to be represented. So I've taken Hema and Sumati. So, we take the lead and the men folks will be the co-investigators. Okay? Thank you. I have to leave for the next meeting. Thank you.
Thank you, ma'am. We'll take it forward.
Good evening, everyone. I thank everyone for giving me an opportunity to present this review of Indian literature on EHPO in children under the guidance of Professor Nimla ma'am. We will have an overview of epidemiology, etiology, clinical features, complications with respect to bleeding manifestations and non-bleeding manifestations and treatment and natural history studies. the definition of EHPO was given based on the consensus on extrahepatic portal vein obstruction in 2006 headed by Sarin sir. EHPO is defined as a vascular disorder of the liver wherein there is obstruction of the extrahepatic portal vein without involvement of the intrahepatic portal veins or splenic vein or superior mesenteric vein. Isolated occlusion of the splenic vein or superior mesenteric vein does not constitute EHPO, and portal vein obstruction associated with chronic liver disease or neoplasia is a separate entity and does not constitute EHPO. Moving on to epidemiology, a study by Podar showed that EHPO is the most common cause of portal hypertension in children in India, accounting for 54% of our portal hypertensive children, whereas the next was cirrhosis. This study also showed that variceal bleeding was most common in children with EHPO compared to cirrhotic children. And this study also showed the differences between the etiology of portal hypertension among children. EHPO was the most common cause of portal hypertension, ranging from 54 to 76%, followed by cirrhosis. In West, EHPO constituted only 33 to 34%, whereas the leading cause was cirrhosis, mostly due to biliary atresia. Moving on to etiology, till now, umbilical vein catheterization is thought of and the most common associated risk factor for EHPO. And in a study to prove that, the Sarin sir showed that despite development of portal vein thrombosis in 45% of our children undergoing umbilical vein catheterization, there is a spontaneous recanalization of our portal vein within 3 months. Prolonged or traumatic cannulation or presence of omphalitis or sepsis were considered as risk factors, and the need for careful surveillance for portal vein thrombosis was reiterated. Are post-thrombotic states common in children, and is the workup warranted? These studies show that the home delivery and umbilical sepsis were considered as risk factors, and though protein C, protein S deficiency and antithrombin D deficiency was seen in some children, none of them harbored a mutation. A study by Sanjay Sharma also reiterated the fact that frequencies of these mutations were not different from those in control subjects, and hence it could be concluded that neither hereditary nor acquired procoagulant states played a role. Despite extensive workup, etiology of EHPO remained predominantly idiopathic, that is around 85 to 90% of the children the cause was idiopathic. Umbilical sepsis was attributed to only 5 to 10%, whereas none of them harbored a congenital or acquired procoagulant state. Children with umbilical sepsis present early at around 3 years, whereas children with idiopathic cause present late at around 8 years. Coming on to the clinical features, this study reiterated the fact that majority of the EHPO children presented with variceal bleed, that is around 85% of the children presented with variceal bleed, whereas only 10 to 15% of the children were diagnosed incidentally either by splenomegaly or some features. The mean age of presentation was 7.3, ranged from 8 months to 14 years. There was a bimodal presentation depending upon the etiology, and overall there was a male predilection. The mean age of first bleeding was around 5.3 years, and the mean number of bleeding episodes was around 1.8 per child, ranging from 1 to 5. Yacha et al. Showed that though rectal varices and colopathy were prevalent in around 36%, there was no increased rate of bleeding, and overall 20 to 30% of EHPO children present with bleed from ectopic viruses. Moving on to portal hypertensive gastropathy, in a study of 274 children on the frequency of gastropathy and gastric varices in children by Podar et al., it was shown that in the first presentation, almost all children had esophageal varices on endoscopy, whereas gastric varices and gastroesophageal varices were present in around 65% to 70%, whereas isolated gastric varices were present in only 2%. Though portal hypertensive gastropathy was seen in 27%, severe portal hypertensive gastropathy was seen only in 3.6%. On follow-up, these children were found to have a significant reduction in esophageal varices and gastroesophageal varices following endoscopic eradication, whereas isolated gastric varices and portal hypertensive gastropathy increased significantly post-eradication, and the severity of portal hypertensive gastropathy also increased from 3.2% to 15.6%. Moving on to the evidences on portal hypertensive colopathy. In a study by SGPJ group published in 2020 on 54 children with EHPO on the prevalence of nature and predictors of colonic changes in EHPO children, it was noted that anorectal varices were present in around 94% of the children, whereas in the previous study it was shown that only 36% had anorectal varices. This study showed that Anorectal varices were prevalent in 94% and colonic varices were present only in 4% of the cases. Overall, portal hypertensive colopathy was seen in 40 cases, that is around 75% of the children. Colitis-like lesions such as patchy hyperemia, small ulcers with flat or elevated margins, large punch-out lesions were more common, accounting to 90%, whereas vascular lesions such as cherry red spots, spider angioma and vascular ectasia were seen only in 63%. Portal hypertensive colopathy was not increasingly prevalent based on either duration or bleeding per rectum or hypersplenism. Whereas portal hypertensive colopathy was significantly increased in children with portal hypertensive gastropathy or large esophageal varices or children requiring increased number of EST or EVL sessions. This study also showed that despite the different extent of splenoportal axis block, left-sided colopathy was predominant. And this study also showed that the capillary to crypt ratio was increased in sigmoid descending colon and transverse colon. Ectopic varices could be either luminal or extraluminal, and luminal gastric varices, duodenal varices and rectal and anal canal varices were common. A triad of portal hypertension, hematochezia without hematemesis and previous abdominal surgery characterizes small intestinal varices. Moving on to the non-bleeding manifestations of EHPO, a paper from our center by Nirmala ma'am and Sumati ma'am showed that splenomegaly was the most common non-bleeding manifestation, followed by hypersplenism. Whereas in older children, anemia was the most common non-bleeding manifestation. Overall, splenomegaly was seen in around 95.8% and hypersplenism in 37.5%, ascites in 10.4%, growth retardation in 22.9% and around 4 to 6% had raised bilirubin and elevated transaminases. Moving on to growth retardation. Growth retardation in EHPO children could be due to portal enteropathy leading on to malabsorption or growth hormone resistance or anemia, wherein Saran sir brought out the fact that 51% of children with extrahepatic portal vein obstruction had stunted growth compared to 16% in controls. And this study also showed that severity of growth retardation increased with the duration of portal hypertension. From various studies in India, we can know that growth retardation was prevalent anywhere from 30% to 66%. And this study by Mir et al. Proved that growth hormone resistance is one of the risk factors or one of the causative agents for growth retardation in children. Here we can see that the growth hormone levels were significantly increased in case of children with EHPO with a reduction in IGF-1 and IGF-BP3. The quality of life in children was studied in around 100 children with EHPO by Krishna et al. Showed that there was no significant differences in the quality of life indices, whereas there was a significant increase in the quality of life score in post-shunt surgery patients, though not up to the level of controls. Here we can see that in children with hypersplenism or massive splenomegaly or growth retardation, the overall quality of life score was decreased, and on multivariate regression analysis, spleen size and growth retardation were found to be independent predictors that affect the quality of life. In a study by our center, it was shown that the quality of life did not differ significantly much in children with during eradication and post-eradication or post-shunt surgery. Minimal hepatic encephalopathy is seen in 32% of cases using neuropsychological testing and 57% of cases by critical flicker frequency techniques. EHPO is an example of type B hepatic encephalopathy, and following shunt surgery, minimal hepatic encephalopathy is more prevalent in non-selective shunts as compared to selective shunts. Moving on to portal cavernoma cholangiopathy, which is the most feared complication in adults, where the children turn out to be, EHPO children turn out to be adults. In a study of 72 children for cholangiopathy in children with extrahepatic portal vein obstruction, Moinax and they have showed that 92% of children had portal cavernocholangiopathy on MR cholangiogram, and among them 85%, majority remained asymptomatic and only 7% were symptomatic. Age at study and duration of disease had a significant correlation with the degree of portal cavernoma cholangiopathy. And MRC grades and superior mesenteric vein block on MRPV significantly corresponded with the ES changes. Supramesenteric vein non-patency was a single strong predictor of MRC biliary changes. And moving on to the long-term outcomes and the natural history of portal cavernoma cholangiopathy, in a long-term study, multi-center study, it was shown that around 620 patients, only 15% had a portal biliopathy, and among them, 41% had shuntable anatomy, and 59% had a non-shuntable anatomy, and among the patients with non-shuntable anatomy, majority remained asymptomatic, and those who were symptomatic with jaundice or CBD stones, endoscopic therapy was done. In a follow-up, long-term follow-up, Kaplan-Meier curve, here we can see that as the patients with the portal PCC are proceeding, the survival rate, that is the decompensation, increases on duration. This is based on the review of literature. Moynihan had proposed strategy for managing children with PCC, and when the child were asymptomatic, they mostly follow-up is only essential, and when the serum alkaline phosphatase levels rises more than 3 times the upper limit of normal, they have to be subjected for early shunt surgery. Moving on to ascites. In a study of 79 children, for ascites in children with extrahepatic portal vein obstruction, they had found out that 16% are presented with de novo ascites, whereas 84% had post-bleeding ascites. And the risk factors for ascites in post-bleeding ascites were younger age of disease onset, low height Z-scores, greater reduction in serum protein albumin and hemoglobin from baseline and non-bleed state. The resolution of ascites was seen in 32% by only salt restriction, and additional diuretics was required in 39% of the children, and large volume paracentesis was required in 29%. As 16% of EHPO children developed de novo ascites due to concomitant secondary illness, it seems prudent to perform a diagnostic tap. Moving on to the management, acute bleed management was not significantly different from adults, and secondary prophylaxis, we know that endoscopic eradication of esophageal varices is a predominant modality, and in case of ectopic varices, earlier shunt surgeries are prescribed. Moving on to EST vs EVL. Though EVL is the predominant modality of management in older children and adults, EST is still done for younger children. And here we can see the eradication rates for EST, where it is pretty good from 88% to 95%. And the recurrent varices rate is from 10% to 17%, and the rebleeding rate is ranging from 11 to 23%. Overall, the complications such as ulcer and stricture were present in around 20%. Zargar et al. Studied EST vs EVL in around 25 patients in each arm and showed that the number of sessions to eradicate the varices was significantly less in case of endoscopic variceal ligation group compared to EST, and rebleeding rates were significantly higher in case of EST group compared to EVL. Both major and minor complications were significantly increased in case of EST group compared to EVL. And overall, rebleeding rate was less in case of EVL, and there was no significant difference in the variceal recurrence rate between the EVL and EST. Coming to the post-endoscopic eradication of esophageal varices and the endotherapy outcome, here Ita et al. Studied around 163 children and saw that around 61% had a primary gastric varices, and among them, after eradication, GOV1 decreased, whereas the secondary varices, especially the GOV2 and IJV1, started increasing. The portal hypertensive gastropathy is seen in increased frequency from 12 to 41%, and the severity was also increased. 11 cases also had rebleeding from gastric varices. The natural history study from South India from Kerala also showed that though GOV1 is increasing on a long-term follow-up, GOV2 and IJV1 started increasing, and the rebleeding rate remained the same at 10-year follow-up. Here we can see that though recurrence of varices is more common, all those recurrent varices did not translate into bleeding, and the overall mortality rate ranged from 1.5% to 2%. And among the various studies, long-term studies, we can see that the recurrent bleeding rate was still less than the recurrent variceal rate. Moving on to shunt surgeries, there is an ongoing debate on the timing of shunt surgeries, whether we can do a total portosystemic shunt following endoscopic control of first major bleed episode, or surgical intervention for select indications post endoscopic eradication of esophageal varices, or a primary mesorex bypass shunt for primary and secondary esophageal prophylaxis for every child with EHPO. But till now, the scenario is every child has to earn for its shunt surgery. due to either endoscopic failure of bleeding management or growth failure or minimal hepatic encephalopathy was failed the usual primary management or impaired quality of life or portal biliopathy. This is a landmark paper when they have studied the portosystemic shunt surgery experience of around 2 decades in a single center from SGPGI. It was a recent paper. It pointed out that non-variceal indications for surgery were the leading ones, which was led by massive splenomegaly and growth retardation, whereas the variceal indications for surgery were little less. And the bleed from high-risk isolated gastric varices and high-risk non-bleeding gastric varices were the primary ones. The most common shunt surgery performed was PSRS next, and followed by gastric esophageal devascularization with splenectomy. The median age at surgery was 12 years, and the mean number of endotherapy sessions performed to achieve endoscopic eradication of esophageal varices was only 7. In a median follow-up of around 41 months, they found that around 11% of cases there was a post-shunt surgery block, and post-shunt surgery block led to recurrent GI variceal bleed, symptomatic portal colopathy, and progression of PCC. On long-term follow-up, it was found out that issues related to massive splenomegaly and severe hypersplenism such as decreased total count and thrombocytopenia were significantly reduced in case of children undergoing splenectomy, and issues of chronic pain, early satiety and easy fatigability all resolved in all the children. And in case of children undergoing shunt surgery for PCC, if the shunt was patent, the symptoms of cholestasis either normalized or there was a reduction in GGT. In case of early PSS thrombosis, the PCC still persisted. And overall, the growth scores and the weight for age scores were significantly increased. Coming on to the rare complications in portal shunt surgeries, there were duodenal ulcer bleed and transient overt encephalopathy or nephropathy, which also resolved in around 8 months. This study showed that there was an overall improvement in weight and height Z scores, more so in case who had undergone splenectomy, and the children returned to school, and there was an overall improved physical activity performance and personality performance. And the cost incurred for surgery was also only 1/3 of the amount spent while on medical management. Mesorex bypass is considered as the physiological cure and restorative process, as it restores most of the blood supply to the liver. And this is an autologous shunt from the splanchnic vein to the left portal vein. So, it is proposed for the primary and secondary prophylaxis of EHPO in children in Bavino's 6 consensus statement. For doing Mesorex bypass, patency of Rex vein is a prerequisite. USG and CT have poor accuracy for detecting patency. So, in ILBS, this recent study had tested wedge hepatic portal venography for the assessment of Rex vein patency in children with extrahepatic portal vein obstruction. Around 31 children they had studied, and they showed that the patency of Rex vein was present only in 29%, and the most favorable anatomy for Mesorex bypass, that is type A, was found only in 13%, and the patency of Rex vein was associated with younger age, and children less than 5 years were 12 times more likely to have a patent Rex vein compared to the older children. And no association of Rex vein patency with local factors like umbilical vein catheterization or prothrombotic states. Coming on to the summary. To summarize, EHPO is the most common cause of portal hypertension in children. Etiology remains primarily idiopathic and prothrombotic states are uncommon. Variceal bleed is the most common presentation of EHPO in children. Splenomegaly, hypersplenism and growth retardation are common non-bleeding manifestations. EVL is better than ESD except for small children. Gastric varices were the most common ectopic varices, and secondary GOV2 and IJV significantly increased following endoscopic eradication of esophageal varices. Portal hypertensive gastropathy was also seen in increased frequency and severity following endoscopic eradication of esophageal varices. Anorectal varices and portal hypertensive colopathy, though was common, did not report any increased bleeding. De novo ascites do develop, and role of diagnostic ascitic tab has to be remembered. PCC is mostly asymptomatic in children, and follow-up is only necessary. Shunt surgeries are most commonly performed following endoscopic eradication of esophageal varices when indicated. PSRS is the most common shunt surgery performed, and post-shunt thrombosis rates remain till less than 15%. Quality of life, hematological indices and growth significantly improved after shunt surgeries. Mesorex bypass is a physiological and restorative and curative procedure mentioned, but still a long way to go in Indian children. Thank you, one and all.
How commonly you see HPO in your institute? Is it common or
Sir, unlike the literature which was mentioned, we do not see mostly idiopathic cases where the children presents in an older age group. Here, the most common association for us is umbilical vein catheterization. As early as 6 months, we have seen varicose bleed following UVC catheterizations.
the umbilical vein catheterization and all? It is now uncommon.
So, still in government setup.
They have started, even in the newborn period, they start their catheterize nowadays. Even for any IV fluids, they are using the umbilical vein nowadays. Only thing they are very they are careful when handling such. That's all. But still they are doing it.
Doctor, two things I would like to know. It's a good presentation. Natural history of EHPO, normally we like it. Thankfully, madam was not there. EHPO and NCPO compare. NCPO progress to DCLD. Whether EHPO also progress? Is there any study on this?
So there was only one paper which was a short duration study. They had mentioned that both ascites was common and they can proceed. But after that, I could not find any Indian literature.
Actually, there are international studies, but not Indian studies. They don't assess this.
Second question, since you mentioned Varghese Thomas, he mentioned about the role of indral, propranolol in non-cirrhotic proliferation EHPO. Do you have any scientific basis for giving indral in case of EHPO and NCPF? Yes, for case of cirrhosis, yes, proliferation. Do you have, there's such a kind of study was conducted? Because his study, landmark study in South India was Varghese Thomas study.
Yes, sir. Sir, actually there is no paper to refute the use of propranolol in children. They can be safely used in case of secondary prophylaxis as after bleeds, yes, after secondary prophylaxis.
See, one thing the postgraduates should remember is that the EHPVO cirrhosis combination. I have seen two patients with EHPVO with cirrhosis, and both of them are hepatitis B related. The transfusions was responsible. So please remember that the cirrhosis, you don't necessarily say EHPVO is producing the cirrhosis because of lack of blood flow. It can be due to the factors in treatment when you are not actually screened and the patient may have hepatitis B or C related cirrhosis.
One more question, sorry. My voice audible. When EPN is there, you will be very part of the Arab case factor. There are any studies on this Arab case factor?
Sir, I didn't.
Factors, the Arab case factors, all those things. Arab case factor, the cleaving factor, this thing, the non-therapy like such a study has been done in India. NCPH, they say totally, they combine the EHPO. That means there is a factor, that coagulation profile, the factor 8 and 9. Arab case factor is supposed to be important. Is there any study you came across last 5 years? EPN is very fond of. They are doing some study in CMC. Whether any paper has been posted in this?
In children, I was not able to find any studies, sir. Probably in adults. Yes.
Can I just make one comment? The radiological appearance of NCPF, many times the radiologists report as irregular nodular liver as cirrhosis. As clinicians, we need to make the diagnosis between cirrhosis and NCPF because they are different prognostic, pathway actually, totally different. So the reason why it appears irregular is because of nodular regenerative hyperplasia that occurs in this situation. So I think that should be emphasized.
Thank you all the postgraduates for their wonderful presentation. I thank the chairpersons for conducting these proceedings. Take another 5-10 minutes to present the secretary report, followed by the CME part. So again, members of Tamil Nadu ISD are setting the flags high, and again, Dr. Chandrasekhar, Dr. E. Chandrasekhar has probably right now being awarded Hippocrates Legacy Award from the Times Group of Magazine today in Delhi, and I think so hearty congratulations to him. And Professor Kandaswamy at Kumar from Tirunelveli has been awarded the Best Doctor Award from the Dr. MGR University for this year, and he'll be awarded the same during the Doctors' Day celebration on July 1st. The fourth edition of the Tamil Nadu ISD ECME was conducted on 13th of June. Due for congratulations and a hearty thanks to the organizing team from Salem, headed by Dr. Rajesh. We had about 50 participants, but I still feel the audience and the participation from the postgraduates could have been better. We have about 120 postgraduates in Tamil Nadu. This is mainly focused on 7 to 8 p.m. Just one thing, once in 3 months. So I think they should be able to attend this. It's an online forum. It is aimed at postgraduates, and I would expect more people to log in and make a benefit of this. We had a 2 case presentation followed by a guest lecture from Dr. Dinesh Jyotimani. So it was conducted well. Another TNISD endorsed CME was conducted on 22nd June at SRM Global for a whole day CME program, which went off very well. So thanks again to Dr. Rajesh for helping organize the meeting. We have an ongoing multi-center study, that's a Plex study, which is still, I think, 2 months more, I think, for to go on for data collection. And now, I think, Professor Jayanti has initiated, at least has taken the lead and said that probably we should conduct a short study on HCC as well as alcoholic liver disease. And probably Dr. Murugan was also saying during the last meeting that probably we should have a study on, at least a registry on autoimmune liver disease. So I think a lot of interest in liver disease, probably I think we can take a lead, and probably as a special interest group, if we can form a forum and present it, I think Tamil Nadu IST can go a long way. I think we have already shown the way with polyp studies and rodenticide poisoning. I think this can go further as well. So key forthcoming meetings, please block your dates for October 19th and 20th. The midterm ISG meeting, Tamil Nadu ISG meeting will be at Kutralam. Professor Kandasamy will be taking the lead and helping organize it. He has already started the work for it. So shortly we'll be getting the program, which I'll be updating you through email. And please make your own travel arrangements pretty early, because as I think only a couple of trains which actually reach there, and probably you'll have to book it pretty early. And the annual ISG meeting will be on February 22nd and 23rd. Tamil Nadu ISG meeting will be on 22nd and 23rd, 2025 at Coimbatore. Shortly we'll be hearing more from that. And I would encourage all the postgraduates to come up with their posters, presentations, and all the midterm ISG meeting. We do have some exciting prizes coming up from that as well. As far as the July meeting goes, I think there'll be it'll be combined with one of the US hands-on program which is being conducted from Kaveri Hospital by Dr. Vishnu. There are faculty who will be coming in from across India who will be participating in that. So in the evening, probably we'll be including them to be part of our ISG meeting. So I think if Vishnu can just briefly mention who will be the faculty. So it will be held at Ramada, Hotel Ramada, for this next session alone, that is in July alone. We'll have some 3 faculties.
It's in the mail. Hi, good evening. I think we have Vikram Bhatia from ILBS coming, and Dr. Sudipta from Velu, and we have Dr. Malay Sharma from Meerut, and Dr. Prakash Zakarias from Lisi Hospital, Kochi. So there will be a discussion, case-based discussion on the theme SOLs in gastroenterology, space occupying lesions in gastroenterology. So predominantly the topic will cover hepatopancreatibiliary mass lesions and subepithelial mass lesions. So that's a case-based discussion on for the next event. Regarding the US. And I would also like to invite you for this meet. This is first of its meet by Tamil Nadu AG chapter's US special interest group. So this is aimed for both the beginners and intermediates and experts. So it's a 2-day event. Please make yourself available for this event next month. Thank you.
It will be on Saturday and Sunday. So in the Saturday evening, we'll have this meeting. We'll have a Tamil Nadu ISG meeting. That session alone, that meeting alone will be held at Hotel Ramada as of now. So with that, I'll again remind all the members to please log in and get your credit points. Please fill up the attendance. It takes less than a minute, so you can scan and please upload your details so that we can follow up for the attendance later. Now I'll request the chairpersons for the CME, Dr. Joymon, Dr. Hema Vijayalakshmi, to come over and conduct the proceedings, please. Thank you.
Good evening. Today it's a privilege to be here to chair this session. We have a galaxy of eminent speakers, hepatologists, interventional radiologists and surgical gastro who will be talking on HCC. And the first talk is by Dr. Hema Malla on Puri recommendations. And some of the hepatologists have contributed to the Puri recommendations. So it's I hope we have a fruitful discussion.
Dr. Hema Malla is a senior consultant and a hepatologist at Miyot Hospital. She had a line of experiences on HCC and NASH and also on liver transplantation.
So, good evening. So, I have been given the task of talking on INASL Puri 2023. It was published as in the January 2024 journal of the JCEH. And what's new and what has changed. So it is around a 33-page document, and so it covers the indicators of aggressive tumor biology, the new INASL BCLC staging, so which is the recommended HCC staging for India, the stepwise management of intermediate and advanced HCC, and how to assess the treatment response, repeat therapies, and the futilities. So this is the third recommendations from the INASL. The first one was in 2014 in Puri, then the 2019, the second one was published, and now this is the third one. So the last one in 2019, basically it was very much similar to the popular one, that is the BCLC classification for management of HCC. So this was the 2019 where you see 4 stages and then line vertical downwards, the what management you have to give. But there were some problems with that, and then in 2022 there is BCLC modifications was done because of the various the advance which has happened in the intermediate stage. So this is the BCLC 2022 update. There, if you see that previously intermediate stage was only one stage, but here they have divided into 3 stages. The extended criteria, the well-defined nodules, and the diffuse infiltrative. But even with this 2022 update, there were some problems. So, and there are more studies coming up, especially with the systemic therapies, TARE and SBRT. So now we have the INASL 2023 update. And you have the INASL BC, it's called INASL BCLC staging. So there are some changes. So let's just look at the changes first. So again, it has the same very early stage, intermediate stage, advanced stage, and the terminal stage. But in the advanced stage, so we know that there is advanced stage means portal vein invasion or extrahepatic spread. So there is C1. So C1 is just portal vein invasion alone, and C2 extrahepatic spread. So this is not new for some of us who have been treating it. We have differentiated extrahepatic spread from the portal vein thrombosis because the treatment offered can be different. And then in the terminal stage, obviously, there is end-stage liver disease. But even if the patient has end-stage liver disease, if it is within UCSF criteria, we can go for transplantation. This is different from what is there in the 2022 update of the BCLC. I'm just talking about the differences. And then third difference is that, in the B stage and the C stage, you can use combination therapies, multiple therapies, along with systemic therapy. So this is one difference. And then obviously the B1 stage, that is those within UCSF criteria, you can go for transplant. Those beyond UCSF criteria, you can go for downstage and go for transplant. And then another difference between BCLC and this here is that the radioembolization and the radiotherapy have been mentioned because of the studies which have been done in between, and they have been used as part of, as a monotherapy or as part of other adjuvant therapies. And then also there is something called as a treatment stage migration, which has been there before also. That means patient comes with one initial stage, and then you give a treatment. So either the patient progresses or the treatment there is a treatment failure, you can go for the next stage therapy. And INACIL recommends that most patients with HCC should go through a multidisciplinary tumor board. So few years back, 4 to 5 years back, if I see a patient with a tumor and I can decide, okay, this goes for ablation, this goes for resection, this goes for transplant. But now it is no longer. And also because most of the patients whom we see are in advanced stage, so they go through a multidisciplinary tumor board, and where the interventional radiologists and medical oncologists are also part of the team. So we will go through some of the stagings and and the management. So these things will be keeping on repeating through that. So basically, what are the treatment modalities which are available? Resection, transplant, ablation, chemoembolization, radioembolization, radiotherapy, systemic therapy, and combination therapy. And then all these modalities, either as a monotherapy or in combination, we will decide based on obviously the the stage, which is the tumor size or number, the tumor biology, the AFP, the liver dysfunction, that is child score, the vascular involvement, the performance status, and the response to previous therapy. So there will be a combination of these treatments which are happening. So we'll go to B1. The early stage, almost it is same as what it is before, so we are not going there. So when you say stage B1, that means, they are intermediate stage, they are multinodular beyond Milan criteria, and with good performance status, good child status. So they are beyond Milan criteria, that means, so all these things are beyond Milan criteria, but then they are all called as extended liver transplant criteria, but INACIL recommends the use of the UCSF criteria for patient selection for liver transplant. That means if it is within UCSF, go straight for upfront liver transplantation. The evidence is moderate and the strength, the recommendation is strong. Patients who are beyond UCSF criteria, but who have good liver function, they should undergo liver transplantation following successful downstaging, provided they meet specified downstaging endpoints. So specified downstaging endpoints, in the earlier it was Milan, but here in INACIL, even if they meet within UCSF criteria, it is good. So the level of evidence is moderate and the strength of recommendation is strong. And no specific region, that means either TACE has to be used or TAR has to be used or SBRT, no specific recommendation has been done for that particular thing. What about stage B2? That stage B2 means they are beyond this extended criteria, but they still have well-defined nodules. The portal flow is intact. So that means this group of patients can be targeted with intra-arterial therapies. And this can be a chemoembolization or a radioembolization. So TACE, as you all know, it can be used as a bridging therapy for transplant or downstaging for a transplant. And it primarily, we are limiting the intrahepatic tumor burden. And the aim is to achieve complete devascularization of the tumor tissue. It is usually done when the child score is less than 8. And if there is extensive infiltration or if there is infiltration of main portal vein, then it is a contraindication for TACE. So the radioembolization. So radioembolization, now we know that maybe the initial studies shows that survival is not different, but that there is significant longer time to progression of the tumor. So what are the recommendation in this B1 or B2? So INACIL says TACE is indicated for HCC patient with well-defined nodules and preserved portal flow, especially in B2, and those in B1 who do not have the prospect of liver transplants for whatever reason. So the level of evidence is very high and there is a strong recommendation. So the use of TAR in B1, B2 is to be individualized. There is moderate evidence, there's a weak recommendation. So when you are using TACE, so again, as we said, in these patients, we can use combinations. So TACE, slightly larger tumors, TACE with ablation. So if you are using ablation, TACE with ablation, then microwave ablation is preferred over RFA because the zone of coagulation is much higher with the microwave. So can these patients, though we know the early stage patients, resection is better, and obviously resection gives a survival advantage over TACE, but in B1, B2, can we consider resection? So obviously they are in cirrhotic patients, there is a risk of decompensation and mortality. But if they are potentially resectable, and if the remnant volume is more than 40%, and if there is no clinically significant portal hypertension, INASL says yes, you can attempt resection. But it also depends on the local expertise. So this is the recommendation. So you can see there is some evidence, but weak recommendation. That means probably people are not confident doing so. There's still only weak recommendation for this. So the same thing. So liver remnant of at least 40% here. So usually after resection, earlier no new adjuvant therapy was recommended. That means any kind of systemic therapy was not recommended previously. But now if in this kind of B1 or B2 patients, if the resection was technically challenging, new adjuvant therapy using local regional therapies can be considered. So that is the recommendation from INASL. Stage 3 and C1. So stage 3 means there is diffuse infiltration or extensive liver involvement, and generally TACE is not recommended because of risk of decompensation. In stage C1, that means there is a portal vein involvement. So those patients who have good performance status, and the CTP score is less than 8, what to do in those patients. Those patients, because of portal vein thrombus, obviously TACE is contraindicated. In this group of patients, so here we will discuss further, INASL recommends systemic therapy as the first treatment, and TAR has also shown promising results in providing effective disease control and improved survival outcomes. So there's a strong recommendation for both, and there's a moderate amount of evidence. And in stage C1, that is just portal vein thrombosis alone without extrahepatic disease, you can definitely consider TAR. So the role of TAR, so it is a much costlier procedure when you compare with TACE, but it has a good safety profile, and it has a good efficacy in the local disease control, and also in favorable long-term control. So this is the classification used for the portal vein thrombosis. So generally, if there is a main trunk involvement, that means GP4, it is generally considered to be a contraindication for a liver transplant or a liver resection. But the segmental or sectoral involvement, we can proceed for resection or transplant. So what is there a role for liver transplantation if there is a portal vein involvement? So INASL says, if there is a major vascular invasion, it is an absolute contraindication. For upfront, so there is here the word, for upfront liver transplantation. So if you are able to downstage later with an SBRT, probably we can. And then there's one next recommendation, which I am not sure whether people will be following. It says, in carefully selected patient with segmental sectoral HCC, and vascular incidence in the absence of extrahepatic metastasis with favorable tumor biology. So there was an initial one page on tumor biology. So we all know we measure the AFP, PIVCA, which are surrogate markers of bad disease, but also now FDG PET. So FDG PET, so if they are FDG avid, that means there is a bad tumor biology. So if all those things are not there, then LDLT can be considered. However, this should only occur following successful downstaging using TAR, SBRT or TACE. So, and also when you re-image that those patients after giving let's say SBRT, there should be no portal vein thrombus. That should completely disappear. And an appropriate waiting period also should be observed. So the evidence is still low and the recommendation is weak. So how about SBRT, that means stereotactic body radiotherapy? This is also being increasingly used. So if you are in a tertiary center where all these modalities are given, it's available, then we can choose. So this is a viable option in stage B. So the SBRT achieves superior 2-year local control rates compared to TACE, and especially when it comes to portal vein thrombosis, it has a better local control. And when TACE plus SBRT is combined and it is compared to sorafenib, so basically, as a systemic therapy, so there is superior progression-free survival, there is longer time to progression, and there's improved overall survival. So when you use SBRT along with TACE. So this SBRT reduces the volume of the thrombus, the enhancement also comes down, and the length of the tumor thrombus also comes down. And as per the published reports, the radiation-induced liver disease is quite rare. And obviously, this also has to be avoided in those in a child score above 8. So the INASL recommends that SBRT is a viable option for achieving local control in patients with intermediate stage, patients who are not eligible for surgery, or those who are unable to undergo local regional therapy. It is also a viable option for those with advanced HCC with portal vein thrombosis. So because it has a survival advantage. Is there a role for resection in C1? That means if there's a portal vein thrombosis, can we do resection? So INASL says it can be considered in carefully selected patient. That means child A, good performance status, no portal hypertension, and it should be obviously resectable. That is a good, residual function, liver function reserve. And the portal vein thrombosis should be limited to the sectoral or ipsilateral side. And in these patients, neoadjuvant therapy may be considered on a case-to-case basis. Now coming to the systemic therapy, this is where there is lots of papers which has come in the last few years. So systemic therapy, stage C2, that means diffuse extrahepatic disease, and also in there is no extrahepatic disease, but there is a diffuse local disease. In these patients, systemic therapy can be used. And systemic therapy means we have both the molecular target therapy, that means the lenvatinib or sorafenib group of drugs, which basically disrupts the intracellular signals which are involved in the cancer cell growth, and the immunotherapy, which basically enhances the body's immune system to fight against the cancer cells. So these are the the molecular targeted therapy, that is like sorafenib, lenvatinib, or regorafenib. So basically they are tyrosine kinase inhibitors. They are multiple receptors on the cell wall, activation of which leads to transcription of proteins, which leads to proliferation, angiogenesis, metastasis. That means it helps in the tumor progression. So if you use these drugs and these are blocked, so obviously the proliferation and angiogenesis is blocked. And then the immunotherapy. So immunotherapy, the drug which was approved was the atezolizumab and the bevacizumab. So it is basically, our body's own immune system is, is going to kill the cancer cells. So the atezolizumab is a PD-L1 inhibitor. So PD-L1 is expressed on the tumor cells actually, and when this atezolizumab blocks it, that means the T cells are again active to destroy the tumor cells. This is how it acts. So basically there is no cytotoxic chemotherapy which is usually not used in HCC. And then bevacizumab is a VEGF inhibitors. So obviously we know that tumors produce these VEGF factors which leads to proliferation and metastasis. So when you use this drug, obviously there is tissue hypoxia and there is killing of the tumor cells. So this is essentially, as per the current INASL, it can be used in almost most of the stages, either in isolation or as a combination therapy. So in the intermediate, the INASL says intermediate and advanced HCC setting, the current indication for systemic therapy as a sole treatment would be obviously C2, that means extrahepatic disease. In C1, if they are not undergoing tear, that means just portal vein thrombosis, if they are not undergoing tear, obviously it is indicated. Then B3 disease, that means diffuse liver disease. And B1 and B2, like if they have not tolerated the local regional therapy like TACE. So obviously it can also be, this one I think we have already talked. The combination of TACE plus systemic therapy, that is sorafenib, so that improves the median progression-free survival as compared to TACE alone. So that means you give a TACE for a patient. Following that, you start them on, nowadays we are giving lenvatinib because of better safety profile, not safety profile, better, side effect profile. So that has a better progression-free survival. So meta-analysis of 30 studies found that TACE combined with tyrosine kinase inhibitors was superior to TACE alone in terms of prolonging time to progression, overall survival, and the objective response rates in patients with unresectable HCC. So Inasil says systemic therapy as an adjuvant therapy, that means along with other modalities. So in stage B, it can be given with TACE, TARE or SBRT. It has not really mentioned as to at what time, before, during or after, it has not been mentioned in the guidelines. And also in C1 stage, so after TARE or SBRT. In patients undergoing downstaging prior to liver transplantation, systemic therapy also may be used in conjunction with loco-regional therapy. So Inasil, obviously, all these modalities can be used only in patients with preserved liver function. So it cannot be used in those above CTP9. And the real world studies has been published, one from AIG also, where they have given this immunotherapy, and the response is good when it is used in child A or early B. If you are using with child C, obviously the side effect profile, and most people do not tolerate the drugs. So the Inasil recommendation, Inasil recommends immunotherapy as the first line. So even atezolizumab and baxdrostat as the first line therapy for in whom systemic therapy is indicated. But for us, the main limiting factor here is the cost. And if it is not feasible, you can use lenvatinib or sorafenib. So the level of evidence is high and the strength of recommendation is strong. And this is another combination which has come up, but it is not available in India yet. And failure of first line therapy, whatever first line you have used, it is failed after, when you assess the tumor response at 6 to 8 weeks, you can again use this. And second line therapy with other, it can be used if the immunotherapy is failing. So what are the contraindications for baxdrostat? So because obviously in cardiovascular disorders and recent bleeding, either GA bleeding or hemoptysis, and those with high risk esophageal varices. So Inasil recommends that those who have large esophageal varices, they have to undergo primary endoscopic band ligation for eradication prior to initiation of the immunotherapy. And once you have given all of these things, all of these therapies, when to reassess. So this is the Inasil recommendation. If it is ablation at 4 weeks, if it is TACE at 4 to 8 weeks, after systemic therapy, then if you give systemic therapy, then it's around 6 to 8 weeks. For TARE, it's around 8 to 12 weeks. So post-transplant, so a patient with HCC, downstage or upfront liver transplant, you take them for post-liver transplant, and then how do you follow them up after the liver transplant? So obviously we should be able to predict the recurrence rate after transplant based on the pre and post-transplant variables. Pre-transplant variables mean the tumor size, either the vascular invasion. Post-transplant variables means the tumor, the biology, the explant histopathology. With all those things, we should be able to estimate the HCC recurrence. There's something called as retreat score. And then here in the post-transplant, CNI levels should generally be kept low to minimize the risk of HCC recurrence. mTOR inhibitors has to be used, and close surveillance. Close surveillance is recommended. So how frequently? So generally the frequency of surveillance is around 3 to 6 months in the first 2 years, and then every 6 months for a total of 5 years. So, and we are almost going to finish. So we have all these treatments, but when is this treatment futile? So how do we define futility? That means futility of a particular treatment in the context of HCC refers to the point at which further treatment using the same modality is unlikely to provide benefits in terms of survival or disease control. So the futility has been described separately for each modality. Futility for liver transplant, futility for systemic therapy, futility for local regional therapy. So obviously for liver transplant, that means elderly patients, significant non-liver morbidity, extrahepatic disease, main portal in thrombosis, outside UCSF criteria, expected 5-year survival below 60%. All these means futile for liver transplant. So futility for one modality does not mean futility for other modalities. So futility for loco-regional therapy, that means after one session of TACE, if there is, there can be a transient decompensation, but that if there is persistent decompensation, then we should not use that. It is obviously contraindicated in child score more than 9, and if there is no objective response at 6 months, or any progression at any time, or increase in AFP, or if there is extrahepatic spread. Futility in systemic therapy. So obviously, if they have very poor performance status, or if the child score is high, so there is so that's also futile. So summary. So we have come to the end. So summary. So basically, because the topic was what is new and what is changed. So so compared to the BCLC staging, which was published in 22, how is this INASL BCLC staging different? So one is the first one is that BCLC, if you open up that first, it just says HCC. But INASL staging mentions HCC with cirrhosis. That's the first difference. Second one is the division of stage C. So, so stage C, that means there is no, here in INASL, C1 and C2, that means those with portal vein thrombosis alone, those with extrahepatic disease. Stage D, obviously, those who, D1 means within UCSF who can go for, who go for liver transplant. D2 means poor performance status or tumor, outside of UCSF. And then inclusion of combination and adjuvant therapy. So that is not mentioned in the BCLC update. So here it recognizes the emerging role of combination therapy, particularly combination of local, regional and systemic therapy. Now this is likely to evolve. So maybe if we have another guideline in 3 to 4 years, like nivolumab was very it came up brightly a few years back, but that is not the first line now. So maybe this is likely to evolve with time. And then there is provision for downstaging, especially if the tumor is beyond UCSF criteria, and the role of radioembolization SBRT. So BCLC has not given that much importance to that, but INASL with the robust evidence, it is supporting for TAR and SBRT, and it has to be included at the appropriate stages.
I invite the panelists, Dr. Murugan, sir, who is a senior consultant at Apollo Hospitals, Dr. Joy Varghese, sir, who is a senior consultant at Global Hospital, Dr. Jaswant, sir, who is a head of the Department of Surgical Gastroenterology and Liver Transplant at Stanley Medical College, and Dr. Monish, who is a senior consultant and interventional radiologist at Global Hospitals. Dr. Ilango, sir, from senior consultant surgical gastro from Miyot Hospitals.
So the discussion will be on advanced HCC. We move towards intermediate, and then we'll move towards early. Usually people talk about early, intermediate, advanced. I'm not going to go into all this complex classification, all those. Very simple: advanced, intermediate, early, how things have changed and how we can manage them. I'll use both the computers actually. So this is a 57-year-old gentleman from Bangladesh. Very similar cases, managed very differently, very different outcomes actually. So he was found to have hepatitis C related hepatocellular carcinoma. This was in last year, May. And then hepatitis C, he was on treatment. He came to us end of last year. So I hope this the video moves. There's a video there. So what we see is elevated alpha fetoprotein, and there is a tumor on both sides, both left and the right lobe. Well preserved liver function test, and then you can see the more lesion on the left side, and there's a large lesion which you will see now on the right side. So this is a multifocal hepatocellular carcinoma. There is portal hypertension, no ascites, well preserved liver function test. So panel discussion, where shall we start? So patient usually comes to the hepatologist, so I'll start with Dr. Murugan first. So what are the treatment options available for this gentleman? Let's not go into the investigations and all. He has HCC,
Thanks, Dinesh. I think the first message to people who are not routinely managing HCC is we should always look for a curative option. Many times it is not done in practice, especially if they go through oncology and come out. So they focus on cancer management. I think the focus should be on cancer and liver management, and always look for curative options. The only two curative options, either resection or transplant. So whenever we see a patient with cirrhosis, with HCC, or even without cirrhosis, first we have to see whether it can be cured. Cured is not an easy word for cancer, but as much as cure we can do. So
Absolutely,
obviously we have to assess the extent of the tumor in the liver in terms of diameter, size. Secondly, the extent of liver disease, whether child A, B or C. And then based on that you decide whether resection can be done. Because it's multifocal with advanced cirrhosis, maybe portal hypertension, resection may not be an option.
Sure.
Then you look at whether this patient is a candidate for transplant.
Sure,
So
good.
this is
Actually,
how the thinking process should go. And then you decide whether he meets criteria, doesn't meet criteria,
Sure.
downstage. Again, I just want to emphasize, in clinical practice it doesn't happen. So even gastro colleagues who see HCC, please discuss with your transplant team, because many times it is not done, referred to oncology, and then they just go into cancer treatment.
absolutely. I think there is a message there actually. Joy, would you be add some more points how we can manage this patient? So this is a 5-year-old gentleman, HCV, hepatitis C related HCC, multifocal, preserved function.
So it's a HCV related CLD with a child A, most probably a non-bleeder. So I need the more detail about the tumor, number of tumor and the size of the tumor. Even though they mention no vascular invasion as a multicentric, so better to go ahead for the whole body PET scan to rule out meds. So then HCV, high viral load, so we have to start the oral antiviral drugs, of course. And based on the number of lesions and any extrahepatic metastasis or that, then we have to look into that whether within the UCSF criteria or beyond the UCSF criteria. Because it's not a candidate for resection, of course, as Dr. Mohan says, it's a multifocal. So other option is the liver transplant will be the curative option in case if it is fulfills within the UCSF criteria.
Okay. So I'll ask Professor Jashwant, in terms of the surgical options here, resection option here, why would you not consider for resection? This is mainly for the postgraduates.
So it is multicentric tumor, or decompensated liver disease, and portal hepatitis is there. Other it is normal liver. There is no cirrhosis, no fibrosis in that sense. If there is dominant tumor on one side, we would not two small tumors on the other side. Means we could do rebuild resection and ablation on the other side also.
Sure, so that is also a possibility, provided the portal pressures are okay. I'll come to this side of the panel in a while. So the story is, if you have somebody with HCC, you need to look at the tumor, you need to look at the severity of liver disease, you need to look at the performance status. So that's how your treatment is defined actually. So that's what the panelists are talking about. So here we have an option for liver transplantation, TACE or local regional therapy, tyrosine kinase inhibitor or immunotherapy. How, Dr. Mala can answer that. How do you choose one or the other actually? Just briefly you can mention that.
So actually you can choose all the three, I mean the local regional therapy or TK immunotherapy, but most commonly in practice we try to choose the local regional therapy initially to see if we can downstage and take him for transplant.
Sure.
So that is usually the first therapy, and in that if cost is not an issue probably we would go for a TARE, but if cost is an issue we might be going for a TACE for this patient. And if they are not responding, then obviously we go for the TK or immunotherapy.
Okay.
The aim should be.
Is he the oncologist that has just arrived? Okay, sorry. Yeah.
So
we don't have an oncologist here.
No oncologist.
Okay. Okay, sorry. Yeah.
So I would see if we can downstage it and take him for transplant. That will be the first option if possible.
So when you see patients like this, you need to decide whether you're going to cure them or whether you're going to bridge them, or it's going to be a non-curative option. So you need to decide which way we are swaying, okay? So this patient did not have a family donor, and...
Can I just make a point and maybe ask one of the surgeons, maybe Dr. Ilango. There are centers doing transplant irrespective of criteria as long as the tumor is within the liver. So no size, no number of lesions doesn't matter. There's a large center who has published on this. INASIL has made a statement, UCSF should be the preferred criteria. Internationally, it is Milan criteria, which is a little more stringent. So as a surgeon practicing here, what is your take on this? Should you transplant anybody, any size, provided it's within the liver?
So I see it like this, sir. The survival of a liver transplantation, if you are able to give a 60% 5-year survival, which is very good, even 50% is very good, no other treatment actually gives this amount of efficacy in survival. So the UCSF and the Milan criteria were originally developed for DDLT. In DDLT, apart from the patient, we have a social responsibility of allocating the organs to the maximum possible social benefit. So I don't think so we should apply that in an LDLT scenario. So in LDLT, I think there is no social impact. I think the benefit should be decided between the donor and the recipient and the equipoise that we can achieve in that. So I think in situations like this, I would prefer and I would support the any tumor, any size criteria. But I think the risk of recurrence will be very high, and that should be taken in the consent. This will never be the same result as what we get when the tumor is within the Milan or the UCSF criteria. So there I think UCSF is close to 90%, and 5-year survival you have to achieve 70% even with Milan. That we will not be able to get. If the patient understands that and we also have that understanding, I think size and tumor or just morphologic criteria to predict aggressiveness of the tumor.
In Medanta, they published 2-3 papers. They are getting 40-45% overall survival at 3 years. So I don't know if they
and still it is better than immunotherapy or a TKI.
This is a transplant where a donor is involved, high cost.
Correct.
So
we understand that. That decision has to be done in discussion with the family.
We will move on to the, because let's talk about that later, little later. So this gentleman received 6 cycles of immunotherapy. Usually in a presentation, you'll see only the, the positive side, but I'm saying that this guy progressed on immunotherapy, although the PIFCA showed reduction, alpha-fetoprotein increased significantly. I saw him yesterday. There is significant increase in the tumor volume, tumor burden. So clearly there is no response to immunotherapy. So what do we do here next? Murugan, I'll get back to you on that.
So your original intent was to see if we can downstage?
Downstage, okay. And see,
so
keep him under control.
I don't know, change.
So
combination, I am not much experience in combination of immunotherapy with something like cabozantinib. Maybe that's another way to
do it. So I'll go back one the next slide actually. So why he is not responding to immunotherapy? Joy, any take on this? Why he is not responding, and what do we do next in terms of the treatment?
What about HCV? Are you treating that side by side?
Yeah, HCV is treated. All those things have been done. No, it's to me this is a dead end actually. If his immunotherapy is not responding, there's nothing much we can do. So I went back to the trial and saw that why people and what is the proportion of patients don't respond actually. If you look at the trials, you need to, particularly cancer-related trials, you need to interpret very cautiously. You need to read between the lines actually. That's very important. So this is the actual original IMBRAVE trial. So where the overall survival on atezolizumab, bevacizumab, you had a very good discussion, a good talk in the previous session. So if you look at the overall survival between sorafenib and the combination of immunotherapy, it's 67 versus 54. So overall the numbers, even though they're statistically significant, it's not a big difference between the two. Okay, and based on this drug has been approved for advanced HCC. But what we are here focusing is what's the percentage of disease progression. So if you look at it here, 58.6%, more than 50% of patients progressed on this immunotherapy with sorafenib it's 66. So it's not that different to sorafenib actually when it comes to disease progression. This is why we need to read between the lines and read the fine prints, because when this is in NEJM, but you need to go back and read that. So there is possible that 50% of our patients do not respond to this therapy. Okay. Particularly if you are NASH, this guy is hepatitis C, that's different. But if you are NASH, you may not respond to therapy that much. And I'm not sure why even real world studies are showing it's very good treatment. It is a good treatment. I'm not saying that it's not a good. It is a good treatment. It is the best opportunity we have, best treatment we have in terms of advanced HCC. But also you should be cautious when you choose your patients like that. And there is another trial, I looked at it. People don't talk about this trial much. This is a cosmic trial. So they used cabozantinib and atezolizumab. So how many of you know what cabozantinib is? And last 2 rows can lift your hand if you know or if you used. So how many of you used cabozantinib? It's a very commonly used drug in HCC management. So I want somebody from there to answer. Ashwin, why are you hiding? So this is a tyrosine kinase inhibitor, next generation of sorafenib, lenvatinib and cabozantinib, okay, plus PDY-L1 atezolizumab. So if you look at the trial here, this is also a very successful trial. The survival, progression-free survival is much better. 6-month survival is definitely better, but the overall survival remains the same. Okay, that's why people don't talk much about this trial. And also, if you read the finer prints, in the intention to treat analysis population, the disease control is 78% with the combination of cabozantinib and atezolizumab, whereas it's much higher with cabozantinib alone actually. So the question is, do you actually need immunotherapy? So that we need to answer that. So cabozantinib alone performed better. But again, this is in the setting of clinical trial. Real world may be slightly different actually. So you need to choose the right patient for immunotherapy. Joy, anything you want to add upon experience with the lenvatinib? That's more cost effective. That's more real world. Immunotherapy is expensive actually. So what is your take on that?
I mean, particularly this case, so usually we'll choose either the lenvatinib or immunotherapy, not immediately to downstage the tumor. Normally, because we have other option like a TACE, TAR, so that will, because 8.5 centimeter tumor, no vascular invasion, and the bilirubin, of course, I think should be less than 3 milligram, normal. So why we have gone immediately to jump to the immunotherapy?
So that's right. So the question is why we did not choose loco-regional therapy for. That's a very good question. Why that was patient choice rather than us doing that. So in fact, this is a patient from Bangladesh. He had some treatment already there. He was not happy, so he came over here specifically for this. So we explained and started him on that. So that's why I'm presenting here. So he should have had some other therapy in between. That's where the issue is. So you should have had like a radiotherapy or a TACE, something for the big tumor, because the tumor burden is still quite higher in this population. So that is why I'm saying. So when you choose treatment, you should be very careful what we are going to achieve with that. Himalaya trial, is this drug, anybody's used this combination? So this is not available. I don't think we should discuss this because once again, this is a non-inferior trial actually. It's not a superior trial, it's a non-inferior trial because the outcomes are similar to sorafenib, but the only thing is these patients survive longer actually rather than on sorafenib. So I always feel bad for sorafenib because every trial it's been compared with sorafenib actually. So sir, I'll ask the surgeons here, if he's been downgraded with the tumor with the immunotherapy, when do you want him for transplantation? What is that? Is there any criteria that you would like him to come for transplantation? or would you still say, he's got initial tumor is big, and even though he's responded, I wouldn't consider for transplantation? Is there anything that you would like to do? So, yeah.
So for downstaging, we can look at the FDG PET. That will give us a good view. Second is the tumor markers, both the PIVCA and the AFP. The AFP should be less than 1,000, and we prefer the PIVCA to be less than 400. We can also look at them pre-moral and post-moral scores. So those will give us an objective evidence of response. The time frame in which we do the assessment is 3 months. And that is reasonable. But actually, if you look at the tumor biology, you have to wait for 6 months to actually see that. That's the best time point. But in an LDLT scenario, 3 months is more than sufficient. And if there is a good response and there is no extrahepatic disease, transplantation can be done.
So, so if this gentleman has a good reduction in alpha fetoprotein, PIVCA, and then radiological criteria, can you enumerate us? How do you assess response radiologically, actually? So somebody who had any treatment, any local regional or even immunotherapy,
Yes.
how do you assess it?
We assess it both biochemically and radiologically. First of all, post-TACE or post-TARE, we look at the enhancement pattern. Even before the TACE, we see the enhancement pattern, because some some lesions are hypovascular. So even a TACE wouldn't work well on these patients. So in patients which are in lesions which are hypovascular or showing arterial enhancement, venous washout, post procedure or post TACE in 6 weeks, we see hypo enhancement, that is lipidol deposit in that lesion, and correspondingly the AFP and PIVCA falling down. And if there are any recurrent, lesions which are remaining, residual lesion, we go for a second TACE for these patients. So again, we in CT, yes, we can see the residual lesions, but we consider MRI far better than CT in those cases.
So radiologically, you should see that it's not just the size, the area of necrosis, what you're going to see, that's how you assess the response, because the size may remain the same.
Dinesh, can I just make a point? Ask him a question.
Yes, sir.
Here, there's a large, I don't know if you were in the beginning of the case.
Yes.
There's one large tumor, maybe 8-9 centimeter.
Yes.
And multiple small tumors.
Yes, sir.
So if you choose some local regional therapy,
yes,
can you safely target all lesions, or what would you choose in this situation? Is
So-
TARE better than TACE, or would you do TACE with some RFA? So what would be your preference?
So I assume that it's a large lesion. So
one is 8 or 9, you said?
Yeah, 9 centimeters. Sorry, I had to
9
go back
centimeter.
to-
So the maximum dose of doxorubicin we can go for any patients are about 150 milligrams. And in practice, we see that we can only mix it with 10 ml of lipidol. So and the 9 centimeter hypervascular lesion will absorb most of it. And we go ahead with a gel foam embolization on this artery, so that the lipidol is not washed out in these lesions. So there is good deposit of lipidol and doxorubicin up to the maximum dosage of 150 milligram doxorubicin. And we would like to do a good job and probably come back for the other lesions later, probably 2 weeks or 4 weeks later in the next scan.
Would TACE or TARE have advantage over conventional TACE in large lesions like this?
Yes, sir. I would say that because we are going to repeat these procedures and TARE is quite expensive when compared to TACE, I would go with TACE for multifocal lesions.
So can we say that if you're planning for TACE, do one side first, allow the patient to recover, do the second side next? Is that correct? So that the patient, there's a risk of decompensation following TACE.
Correct.
So you should be very careful in such
One
scenarios.
more point on this. The SBRT guys in our hospital are saying that they can tackle any size of tumor, not a problem, with very good success. I have very limited experience.
We'll talk about that. There's a slide on
I
that.
would like to add one point. We go by the formula that we don't treat more than 3 segments in one sitting. So we keep that in mind. Unless it is small lesions in 3 different lobes and we are able to achieve super selective cannulation of these arteries, we can go ahead with this 150 milligram doxorubicin, 10 ml lipidol in all the 3 lesions. So only.
Do you look at liver reserve volume? How much of normal liver
Yes,
is there?
yes.
Any percentage? 30, 40%?
We want at least 40 to 50% reserve volume.
So we'll just move on to the next case. So the first gentleman, cirrhosis, HCC, multifocal, did not respond to immunotherapy. This is a 59-year-old gentleman with some brain aneurysm in the past, and he had some right side abdominal discomfort. This all happened in Mumbai. So he had a CT for weight loss and right-sided abdomen discomfort where it showed a 9 centimeter lesion HCC. I don't have the image, but I'll show the other images later. And 2 lesions on the left side, very similar to the previous gentleman. Again, his LFTs are normal. So his alpha-fetoprotein 124, PIFCA was very high. He had a biopsy that showed well-differentiated HCC. Treatment options for him, I'll start with Dr. Hemam on the other side. So similar gentleman to before, probably NASH cirrhosis. He had a 9 centimeter HCC on the right side and a few small lesions, like 2 to 3 lesions on the left side of the liver. No vascular invasion. AFP is 2, where is that? AFP was 124. So would you, what would be the treatment in your approach actually? Yeah.
So obviously is outside transplant at present. So again we have to is good liver function. So obviously we have to go for a loco-regional therapy if feasible. So either TACE or it's a large tumor, generally TARE would have a better loco-regional control if it is available, TARE. So I would consider that, even though there is no portal vein thrombus, but for a better loco-regional control, we can attempt TARE here. Followed by probably a lenvatinib.
So can I ask the interventional radiologist, pros and cons of TACE versus TARE? If you can tell us in 2-3 lines, that will be good for.
Yes. So as you know, it's one is radiation and the other is chemo. First thing is we have to look at the lung shunt for a patient with TARE. So that is the first step. So if the lung shunt is going to be more than 20%, TARE is ruled out for this patient. So TACE and so TACE will be better in patients where the lung shunt is more than 20%. Otherwise, we land up in radiation-induced lung disease. And second thing to note is TARE, when the lesion is very close to the diaphragm or very close to the gallbladder or any other important structures, TARE probably causes radiation necrosis of that lesion. So we need to avoid radiation exposure to those organs like gallbladder or probably chest wall as well. And importantly, portal vein invasion we consider TARE because in those patients with portal vein invasion with lung shunting less than 20%, and TARE does a very good job when compared to TACE in these patients.
So TARE is probably slow and slow acting over a period of time. TACE is little quicker, mainly for the main tumor bulk it reduces, whereas TARE also addresses the portal vein tumor issues. So this guy underwent transrectal embolization. I guess there was some rupture of HCC and then followed by TARE actually. Obviously, yes, money. Okay, so and then for smaller lesions, he underwent radiofrequency ablation. Then he underwent immunotherapy. The immunotherapy was atezolizumab with lenvatinib combination actually. So it was treated in Mumbai. It's very clever because they didn't use bevacizumab because there's a risk of bleeding with bevacizumab. So have you encountered Joy Murugan with bevacizumab?
So we usually, before to start the therapy, usually do the endoscopy. If the grade 3, grade 4 varices, we won't subject the patient to the bevacizumab. So immunotherapy that time. So we'll do the prophylactic banding and the patient will be on lenvatinib. So once the eradication of varices, that time we have started the combination of the atezolizumab with the bevacizumab. That was the thing. The active bleed we have not seen because we are choosing particularly as per the recommendation. So the large varices or already the past bleeder we are not choosing.
So patients who have large varices, they should be banded before you start them on anti-VEGF, bevacizumab therapy actually. So that's a point to learn here. And also they didn't start because they were worried about the aneurysmal bleed. So they started this, and then he responded very well actually. So if you can see here, the main tumor is necrosed, and also there are some lesions here and there, but he has done well in terms of the radiological criteria post local regional therapy. And then he came to us, we did a PET CT, there was some active lesion in the left lobe, the AFP is slightly higher, so we suggested him transplantation. He underwent a transplantation last year. So which is better, sir, cadaver transplantation or living donor transplantation? Cadaveric transplantation, so you can talk about which is better for this gentleman, patients like this who's been downstaged.
Cadaver transplant.
So why?
Because we are not putting the, don't run the risk, no.
Okay.
It is comes under criteria.
Okay. So cadaveric transplantation, one, because it's available, and two, because you're not subjecting the donor for risk. That's better. So your chance, sir.
That's a very difficult question to answer. I would also prefer a cadaveric transplantation because I feel that the growth factors released from the growth of the liver can also promote tumor growth as well.
Okay.
But this has not been reflected in practice actually.
That's right, yeah.
So I think it is good. Theoretically, cadaveric transplant appears to be better, but in practice, it actually makes no difference.
It's true. In an ideal world, yes, he needs a disease donor transplantation. If he was in the US, you'll get a priority meld for, but here, in our country, we don't have such policies. So waiting for cadaveric transplantation can have an impact on the tumor recurrence. If he waits for 1 year, it's going to have tumor recurrence, and we're going to miss the boat. So
that's true.
That's one of the problems of waiting longer in the cadaver list. But if your list is short, then you can even go for disease donor transplantation. But this gentleman underwent living donor liver transplantation. 6 months later, everything is fine. This is the current CT, no recurrence, but we are continuously monitoring him sort of every 3 to 6 months with scans and tumor markers, as Dr. Hema Mala suggested. Just briefly touch upon the immunosuppression. What is your approach to immunosuppression here in these sort of patients?
So obviously we will run tacrolimus at the lower level. So around 2 to 3 or maybe up to 2 to 4, and add everolimus. So especially we will start after a month if possible, and because risk of recurrence is higher with CNI. So mTOR inhibitors are better. So usually they will be on tacrolimus, low dose. We can't do away the tacrolimus, but low dose tacrolimus with everolimus.
Yeah. So the treatment for immunosuppression is keep the immunosuppression on the lower side, add mTOR inhibitors like everolimus, because it has, in addition to immunosuppression effect, it also has anti-cancer effect, and keep the tacrolimus on the lower side actually. So you need to find balance. It's nowadays immunosuppression is very tailor-made actually. Dr. Murugan.
Just a question and point for discussion for anybody. Is there a role for adjuvant therapy? This has not been confirmed by studies, but people are using it, especially if there's been a difficult tumor that they have downstage, or biologically unfavorable tumor, or microvascular invasion, or some bad characteristics in the explant liver. Anecdotally, there are people using it, but I know there are no studies.
There is one Chinese study on that, use of lenvatinib post-transplant. It does show benefit in these patients, but the question is how long will you give, when do you stop, how do you monitor them?
For recurrence, there is data.
Yeah.
But in this situation where you want to start from day one.
Yeah, there is one study on that, Chinese study on that. Okay. So this patient underwent TARE. TARE is very expensive, 10 times the cost of TACE. So how do you choose this patient, TARE or TACE? I know you mentioned earlier. So in this scenario, how do you choose TARE over TACE or TACE over TARE? Because I thought I would have gone for a TACE here, looking at the tumor, but he went for a TARE. So how do you choose, as a clinicians, how should we look into these things?
Again, if you can go to the previous slide, I want to show for the radiological images. Yeah. So here we definitely have two lobes being involved. So when I see two lobes and tear is going to do something like a radiation hepatectomy. So if it's going to be only the right lobe, yes, I will go for tear. When I see both lobes involvement, I would prefer TACE over tear in these patients. And second thing is, when the tumor is enhancing uniformly and does not have any areas of necrosis, I will prefer TACE. I'll prefer tear.
Tear.
When there are areas of necrosis and the chances of rupture of the tumor, I will not choose tear in these patients.
So you choose TACE because the tumor is on both sides and one is the larger.
Correct.
For the larger you choose TACE, and for the rest we can manage.
Yes.
I mean, he had immunotherapy, but yeah. Okay.
We can choose serial TACE as well for these patients.
Okay. So how, I just want to ask Dr. Ilango, so post-transplant, the risk of recurrence is there with him, okay, because he's been downstage and he had, transplant. So how do we monitor him? Like, what's the surveillance protocol? Is there anything that you would tell us how we should monitor him?
So for the first year, it is CT scan and with PET every third month, and with the tumor markers. So that's the only follow-up we do. That's more than enough, and with the immunosuppression on the lower side. But apart from that, we don't change anything.
Okay. And second year, similar protocol?
6 months. It changes to 6 months. The duration prolongs. We keep them under follow-up for 5 years, and then it's annual checkup only.
So post-transplant, for high-risk patients who are risk of recurrence, HCC recurrence, you should do images every 3 months in the first year, and every 6 months in the second year, along with the tumor markers if they are secreted. So you should follow them very closely. The recurrence is not going to be in the liver. That's a point you should understand. It's going to be in the lungs or in the bones. So therefore, you need to do a whole body imaging like a PET or a CT chest and abdomen like that. Okay. And this should be explained. Time is up, is it? So role of radiotherapy in patients, we'll come to that. So that's the next question. So when do you choose radiotherapy over TACE or forget over TACE? Murugan.
That's what I said. Right now we are only doing SBRT for extrahepatic disease like portal vein thrombosis. Mostly within the liver, most of us are comfortable with the local regional therapy. IR team is doing it. And they are also having good experience. So SBRT, especially with the newer technologies like proton, is something new. I have very limited experience to say that this is better or not better. Definitely if there is some technical issue with the TACE or TARE, which is very rare, then we can consider.
Think about, okay.
And certainly for portal vein thrombosis downstaging, SBRT seems to play a good role. There is data for primary tumor also that SBRT can play a role, and like I mentioned, there is discussion with the radiation colleagues that they can even do larger tumors with good success. But I don't know if any data is there, and I don't have personal experience beyond this.
Joy.
Whenever we are seeing the HCC with the portal vein tumor thrombus, so the two options we can choose. One is the TARE. Second one is the SBRT, particularly to focus on the portal vein tumor, because even though radiation oncologists, they are saying it will cover the tumor intraparenchymal, the liver tumor and the portal vein invasion, but in practice we are seeing very good response with the SBRT with the portal vein tumor thrombus. But the patient need some sort of TACE also for the HCC. Or TARE means one sitting that will cover the tumor and the portal vein tumor thrombus. But if SBRT, what is our experience wise, we have to target TACE for the liver lesion, I mean the intraparenchymal tumor, and that for a portal vein tumor thrombus, SBRT combination. So SBRT, usually we are giving the 5 sittings, alternative, Monday, Wednesday, Friday, and the next Monday and Wednesday. So 5 sittings, it comes as a package, 2 lakhs rupees only. So most of the time, 6 weeks later, whenever we are repeating the CT abdomen triphasic study, it shows the good response in the tumor thrombus. It's not showing the uptake. Some of the patient little bit late, even the 8th weeks or 12th weeks also. So our experience, our data-wise, portal vein tumor thrombus, we can target the lesion using the SBRT as a better palliative care.
Yeah, I agree with that. So 5 to 7 years ago, this was not the case actually. So only in the last 7 years we've been using more radiation therapy. And when I speak to our radiation oncologist, he says HCC is radiosensitive. And we are seeing that actually. So the portal vein tumor beautifully disappears following radiation therapy. And after that, you can give a TACE to the main tumor. And so you have SBRT alone, or you have combination of SBRT with TACE, or sequential SBRT followed by TACE. So you have various combinations to play around actually, and that's a really opened up what we can do for these patients. And
just one more point, Dinesh. I think what you said is a good point, that the response to HCC for SBRT seems to be very good, and with the newer technologies, they're able to give more precision radiation at higher doses. So I think it's something we should explore even for primary parenchymal liver tumor. The only thing I've noticed is anecdotal 3-4 cases is that the damage to normal liver tissue or some kind of decompensation seems to be more with SBRT compared to TACE and TAR. Maybe it is not enough experience by the radiation team.
So we have encountered radiation gastritis causing bleed, pneumonitis, and hepatitis. So all these.
So when they are vulnerable, they decompensate.
So again,
I think there's something we have to learn over the next.
So we need to learn which patients will benefit from radiation therapy and how we can manage them. So yeah, radiation therapy is quite useful in HCC, particularly in those with portal vein invasion. So this is what the INSL consensus is. If you have somebody with vascular invasion and if they respond very well to radiation therapy and followed by other local regional therapy, you need to watch them for 3 months, ideally 6 months. You can watch them for 3 months. If there are no new tumors, if they are very stable disease, you can consider them for liver transplantation if there is no extra hepatic disease, and you have to demonstrate with PET CT that there is no active portal vein tumor thrombus. Again, intermediate stage. So advanced stage, we had some discussion on that. Intermediate stage is where you even think about transplantation, again local regional therapy. So this study looked at the combination of TACE with your durvalumab is your PD-L1 inhibitor. Again, they've shown a good response. So this is maybe the future actually. This may come across giving TACE with injections, atezolizumab, etc. So they may respond well. One particular area of interest is again going back to radiotherapy plus immunotherapy. So this combination probably will do better in the future. That's what it is. Any idea how it works or? So I learned it very recently from ILBS, from Professor Sarin's lecture, one of ILBS lecture. So actually SBRT, what it does is it's a heat, it's an inflammation. So it causes inflammation of the tumor microenvironment. So you're recruiting all your T cells, which have been quite dormant because of the tumor. That's the whole idea of immunotherapy. You're activating a T cell. So radiotherapy recruits your T cells into the tumor microenvironment where your immunotherapy can act. So this will be an interesting area to see in the future. So patients have SBRT followed by immunotherapy. They have a better response. Earlier studies, I think there is some better response to treatment, but it's very preliminary data. It's only available. So that can something we should look at. So what I'm trying to say is HCC management is moving boundaries. So from advanced to intermediate, you can downgrade them to intermediate, and from intermediate, you can cure them actually. That's the whole idea. So what is the risk of immunotherapy for patients on liver transplantation. Any experience here? I don't think we have much experience on this. Anything you can talk about? So basically, they looked at a very recent study. They looked at all the case series and reports of 45 patients who received immunotherapy before liver transplantation. So acute cellular rejection, because immunotherapy, it increases your immune function, therefore you are prone for rejection. Autoimmune disease, you are prone for all those. So rejection was observed in 1/4 of these patients. So 24% of patients had rejection. So the question is, how long will you wait from immunotherapy to transplantation? So that's where the half-life comes into play. So the recommendation is to wait for 3 half-lives. So if you are using atezolizumab, so you have to wait 3 times 27 actually. So 75 days like that. So that's what you should wait for. But again, that will also give time for us to assess the tumor recurrence in these patients. So what are we going to talk? Yeah. Downstaging criteria. So we talk so much about downstaging. So can anybody define downstaging? Has anybody seen patients downstaged? In the back row, I want them to answer. Third year postgraduates, anybody there? What is downstaging? It's very important to understand because you will be dealing with this. So what is downstaging? Anybody? Okay, so what is the downstaging criteria? So every talk of HCC involves downstaging. Okay, the word down, I didn't know for a long time what downstaging actually refers to, because there are different definitions and it was very subjective until these things came. So downstaging, Murugan, you want to talk about how do we define downstaging? And radiologists can pitch in actually.
I think you fix a criteria which is your threshold for transplant, and when the tumor size diameter is beyond that criteria, you give therapies to reduce it to within the criteria of transplant. But different centers, different countries, different bodies use different criteria. So you have to define your criteria and then bring it to below that. So that's basic downstaging.
Joy.
Maybe there's more clever definition, but I don't know.
So fully agree, because here the biochemical values for tumor marker, we can fix the criteria. Some of the centers to fixing AFP should be less than 200. Most of the studies shows should be less than 400 to go ahead for liver transplantation. Otherwise, the chance of recurrence will be there, even though imaging wise it might be within the UCSF criteria. So within the UCSF criteria or within some Milan criteria, but AFP is more than 400. So the recommendation is better to do some intervention to downstage, to bring down the AFP to less than 400. So that's why the center to centers are moving. But at the same time, even though within the millions are UCSF, more than 1,000, we shouldn't operate. We shouldn't go ahead for liver transplant. Contraindication. So downstage varies. I mean, that's why the biochemical values. Similarly, radiological imaging way, the number of a tumor. That time there are the difference. Seoul, they have their own criteria. Japan, they have the different criteria for the HCC in liver transplant. So in general, we are following the UCSF criteria, but there are centers doing going for liver transplant, even though beyond UCSF criteria. Center-wise, they are choosing some downstaging techniques.
So if you see patients with HCC, there is Milan, it's commonly practiced, Milan criteria, UCSF criteria, there's metro ticket criteria. So there are, if you go to Japan, as Joy said, the different criteria. So Milan has the best recurrence model because the recurrence is less than 5 to 10% post-transplant recurrence. So when you see patients above Milan criteria, you need to downgrade them to Milan criteria. So that is one of the main definitions of downstaging. So you should bring the high-grade tumor into the low grade, and you should bring the different stage, it's called stage migration, from advanced stage to intermediate stage. And also you should look for the necrosis in the radiological images. So the radiological downstaging and biochemical downstaging. There are many centers in the West, they don't offer transplantation. If your AFP is 400 some centers, from some centers about 1,000. But they are also changing. You need to see the delta change. What is the AFP? If somebody's AFP has dropped from 10,000 to 1,200, then that's a good response as well. But in some centers, you still won't get a transplantation. But what INASL has suggested is, recommended is, you should downgrade the UCSF criteria. So that is an indication for transplantation. That's what we should also follow. So patients who don't have adequate downstaging, then you should change the modality of treatment, or even should not even offer transplant if they don't get downstaged. So how long will you wait from downstaging to transplant? Ideally, Dr. Ilanga, you were talking about that earlier. So how long would you want to wait? And what if things are not going in the right direction? What if they have recurrence? What you do? And in terms of why we should wait, what is this tumor biology, what people talk about?
So the basic understanding is that we are trying to assess whether the tumor has micrometastasis we are missing in an advanced, locally advanced HCC. So we downstage them, and then we have to reassess whether there are tumors, extrahepatic disease, as well as how much the tumor responds to treatment, which is a surrogate for the biological behavior. So I think the best duration, if you look at all the statistics, comes down to 6 months. That's probably ideal, but I think practically, I think a lot of us have stuck to 3 months as a sort of balance and compromise to assess, and we find it useful to actually take a decision to go towards liver transplantation. If the tumor progresses during the observation, then you have to avoid transplantation. Probably that's the only safe thing. In disease donor programs, in large disease donor programs like US, 6 months waiting will usually happen. I think the initial activation itself takes 3 months, so 6 months will invariably happen. But in an LDLT scenario, 3 months is more than enough. Have I missed another question?
No, that's a question actually. So basically, if you do any loco-regional therapy, you need to wait, monitor them. Basically, you do repeat scans for 3 months and then see how the response to treatment is. So the first question goes back what we discussed in the first point. Are we going to cure the patient? Or are we going to just control the disease? So if you're going to aim for cure, you need to you need to be more aggressive. That means you're preparing the patient for transplant, see whether they can be transplantable. So that's a cure you're trying to achieve. And so in that, after a local regional therapy, wait for 3 months and see the tumor biology. If the tumor comes back, then the patient is not for transplant. If the patient remains tumor free or in the same stable disease, the alpha fetoprotein remains stable, then they should be considered for liver transplantation. So the next two slides will complete it. It's mainly for early HCC. So we talked about advanced HCC immunotherapy, intermediate immunotherapy, and now we talk about early tumor. So as a surgeon, would you accept somebody who's for resection, don't want to undergo resection, they want to take other therapies? What's your take on that?
So resection is based on the status of the liver, performance status of the patient, and disease status. All the three are perfect. The choice will be for resection. Nowadays, for laparoscopic resection, small tumors can be resected, completely removed without any problem and all, without any much complications and all.
Yes.
The same time, completely we are removing the tumor. We don't have any doubt about that.
Correct.
Ablation means we can leave behind some things, other complications. So with laparoscopy and robotic, more and more liver resection can be done without much complication, without much liver decompensation also.
Sure. So early HCC, that means less than 2 centimeter, around 3 centimeter. If they are in a feasible position, I would say non-cirrhotic or child's age cirrhosis, no portal hypertension, resection is possible, and that is the first line of therapy, and that is considered as curative option therapy in these patients, rather than going for loco-regional or immunotherapy. But there may be situations where you may not be able to operate immediately. Say, for example, if the tumor is in the centrally located tumor, that's still resectable, but you need some time, or comorbidities, or the remnant liver you need to improve. So these may be the indications for other therapies. So would you, I don't know, would you accept that, yeah, okay, let the patient go for immunotherapy, I'll wait for 4 to 6 weeks, or would you be more aggressive in your approach? This is, we are talking about non-cirrhotic liver who are potentially resectable tumors.
Non-cirrhotic livers, we invariably resect in our unit. The remnant liver of 30% is more than sufficient in a non-cirrhotic liver. So we go for resection because it's still a curative treatment. We have never tried immunotherapy. There are studies to show local regional therapy, which we are comfortable with, to go ahead before we do the resection. But as long as the remnant liver is more than 30%, we actually go ahead for resection in a non-cirrhotic.
Sure. So if you do TACE or local regional therapy, how long would you want to wait, or should we just go ahead immediately, or is there any time frame from local regional therapy to resection?
Honestly, we have never done local regional therapy followed by resection. That's never been our experience, especially in a non-cirrhotic patient. So I probably am not the good person to.
So if somebody who has no cirrhosis, even if the lesion is large, as long as the remnant volume is more than 30%, you should still go for resection rather than attempting any local regional therapy. That's a point to learn. There are some studies coming up, use of neoadjuvant immunotherapy in the setting of resection for HCC. Mainly they have used nivolumab up to 3 cycles, but I think it's all depending on the anatomical locations and all those. So how do you monitor patients with HCC who had resection actually? Is there any protocol for that we should follow?
Again, same in 3 months or 2 years, then 6 months.
6 months, okay, 3 years, okay.
With
I think
markers and ultrasound initially, then every year CT scan.
Okay.
Dinesh, so what about after the resection, any neoadjuvant therapy for the HCC?
No neoadjuvant therapy.
So no role for lenvatinib or okay.
No.
Okay, that's fine. So thank you. And I wanted to show one slide from the EASL abstract. So we talk about systemic therapy, immunotherapy. So question is, what is a complete response where there is absolutely no tumor? I found this abstract very interesting. So how many patients achieved complete response from immunotherapy after 12 months? Here is the answer. So out of 2,500 patients they looked at for palliative therapy, 4.9% achieved complete response by different criteria. So it's around 5% of patients who achieve complete response. That means they are completely tumor free, no tumors, also like a stable disease like that. No, they are good biology tumors still. So question is that cost effective when you talk about 5% achieving complete response on immunotherapy? You can.
No, actually 5% response is nothing.
It's a complete response. So most of them will be stable, the 40%, 50% are stable.
The curative option, only the resection or transplant.
Yeah.
Whatever the interventional radiology technique or lenvatinib, sorafenib or immunotherapy, everything comes under the palliative. No one comes to the curative. Even though whatever the complete immunotherapy response shows, the 5% is almost, as far as we can be concerned, it's almost not useful to our population.
Yeah, absolutely. So before we wind up, Dr. Hema, do you want to pitch in some points to conclude in the HCC, mainly for students, in the background?
So HCC, from what it was, 6 to 7 years before, so now we are approaching in a more multidisciplinary way. It's not limited to the hepatologist or the surgeon. It is a multidisciplinary with the involvement of medical oncologists as well as interventional radiologists. And as we kept on repeatedly saying, curative option is resection or liver transplant. Whatever modality we try systemic therapy, we try lenvatinib, immunotherapy, or TACE, unless if you are able to bring the patient to a transplant or a resection, that is a curative. Otherwise, it is a palliative option. So we have to work towards that as long as the patient tolerates or patient develops any side effects.
Excellent. Yeah, thank you. Hema ma'am, what about you? You want to add 1 or 2 points?
No,
Nothing to add. Only thing I just wanted to say, whereas she spelled out all the guidelines in black and white, you managed to cover all the gray zones and all. So now I have an idea where taste, tear, what about the radiotherapy? So
Thank
it's
you.
very
Thank you very much.
useful.
Yeah. So I conclude saying that immunotherapy has invaded HCC management, definitely. In advanced HCC, although better response than sorafenib, disease progression can still occur, so you need to watch out for them. And in intermediate stage and even in advanced stage, you should downstage the tumor with combination of local regional therapy plus tyrosine kinase inhibitors, or in future with immunotherapy if the cost comes down. In early HCC, immunotherapy is too early to recommend. So thank you, panelists. And oh, sir, you have a question.
Can I just have a doubt? Now, suppose there's a de novo patient within the Milan's criteria, you're doing a liver transplant, and then you're looking at survival, recurrence, etc. Then you're downstaged somebody and then doing the liver transplant. Has there been trials to say what is the long-term survival?
If you have effectively downstaged them to Milan criteria, sir, the recurrence is similar. So that's what it is. So, but you should follow them up closely, actually.
Actually, I can say in the different. Whenever we, after the transplant, the explant liver, whenever we are seeing, that time we will look into that, the nature of the tumor. So mostly they will, pathology will write a modulated differentiated, because we are not doing the biopsy before the transplant. At CC, going for transplant, either downstaged or not downstaged, based on the criteria. Okay, so moderately differentiated or poorly differentiated, or sometime coming, the biopsy shows the combination of the cholangio with the HCC. These patients' outcome even after liver transplants are slightly poorer than the routine other cases, because these patients, the histological ways also, we can predict, we can maintain the low immunosuppressive and we can add the mTOR inhibitor, but there is a chance, I mean, there are papers, so many of them, recurrence are more. So that's why the histology, we have to look into that, mostly the moderate or poorly differentiated. So the downstaged, definitely it will show the good outcome compared with that, I mean, because that all, as I already discussed, the AFP, etc., etc. But the histology is the key to predict that.
Okay. Thank you. Thank you, everybody. Thank you.
I would like to thank the participant, postgraduates, the panelists, moderator, the speaker, the invited interventional radiologist for making this evening bright academically. So I'll ask everyone to scan the QR code so that you can get your attendance and credit points in a later time. I'd like to thank La Renan Residency Tower providing this ambience. So I'll request Dr. Thai Manavan sir to present the certificates of appreciation for the postgraduates. Dr. Deepa. Dr. Jagadish Menon. Sir, you can stay. You can stay. He is left. Okay. Dr. Megha Sharma. Dr. Muthukrishnan. He is also on. Thank you, sir. So thanks everyone for making this event more educational, and I'll invite you all for the US conference which will be happening on July 27th. So postgraduates, make yourself free and utilize the time, and we'll meet next time at Hotel Ramada on July 27th. Thanks everyone. Sorry ma'am? Ramada Gindi, yeah. Is that right? Ramada Gindi. So let's join for the cocktail dinner now. Thank you so much. Bye.